So I will call to order the Board of Health, and first up on our agenda is to approve Academic Health Department agreement with the University of Montana School of Public and Community Health Services and authorize the Vice Chair to sign the letter. Ellen and Tony Ward is with us today
Yes.
from the University of Montana.
Tony, if you would go sit at the speaker's table there.
Plague. And then the thing downstairs stole my money, so.
And I just want to say that I feel very awkward with you all at my back, so if we need a correction or something, throw, but we had our TV break, so we had to reorient it. So Dr. Tony Ward is the chair of the Montana at U of M School of Public Health and Community Health Sciences. And that in and of itself is really thrilling. Those of you that haven't been on the board for very long may not know, I'm going to brag because you never will, that Tony Ward worked with Garen Smith like way back, I think when you were working on your PhD or postdoctorate. And our source apportionment study for what are the sources of the PM2.5 in our airshed was one of the products that he did. And then he worked as a professor in chemistry, and then in the new public health school, and in the last, is it 2 years, Tony? He is now the chair of the public health school, which is, I call it that, it's got another name, and it's where I got my master's degree in public health, so I'm very attached. And we've been working together on a lot of organic connections as the public health school grows and we change here. And one that we want to propose today is to sign a memorandum of understanding that's in your packet between this department and the University of Montana to form what's called an academic health department. And an academic health department is an opportunity that is really created and recognized by the Council on Linkages of Public Health, which is like 23 different agencies that care about public health at the national level, between schools and nonprofit agencies, and to just strengthen public health in general. And 3 of their current initiatives are to, well, one we've already had to be measured and approved on, and it's the council created the core competencies for the public health workforce, and those are worked into our accreditation measurements now. So we have adopted those and use those and demonstrate those, and the school teaches along the competencies. Their other initiative is to develop more academic health departments and then help them develop. There are the general, you can think of an academic health department as sort of a teaching health department, kind of like a teaching hospital. It doesn't all take place in the hospital. You obviously have to have the academic piece. Some of the attributes we already have. There's about 9 attributes, and we think at some point by forming this we can formalize ourselves, recognize, have others recognize us, and then we can join this national collaboration, and they have a learning community and some other things to help us to learn how to develop this. So we're really taking the organic and formalizing it for the purpose of identity and growing it. There are 24 states that have academic health departments. Montana doesn't yet have one, so we would be the first. And among those 24 states, there's 62 academic health departments. So I talked with a couple folks in Alabama before talking with Tony, and some of them, for whatever reason, I think they had some tremendous academic leadership 20 years ago, formed this idea and has produced a lot of the templates for how to start and MOUs. So with that, I would ask Tony to maybe speak to whatever you'd like to say about this.
Yeah, at the University of Montana, I think our school is super excited about this potential opportunity. It's already organically happening. We have a lot of staff here at the health department that is current students or alumni of our program. And Ellen could probably teach most of the classes that we offer in our program, so she's one of our star students. for our master's students, and we also have a PhD student, I think it gives our students great opportunities to get some practice experience. So working at the health department on ideas that the health department might have or need help with. It just gives our students really practical experience working on health department priorities. And at the university level, we would be happy to serve as technical resources for the health department if ever there is that need. And again, this just kind of builds on something that's already organically happening. So we're excited for the opportunity.
It's really great. Thanks.
I have a budget question. Do you have a staff cost estimate on?
Nope, we're not.
Okay.
We're starting with what we organically have and what
Okay.
Tony and I can
Good
put together
question.
in the first year. The one, it's really kind of an open-ended opportunity. The one thing that we committed to for this first year and thereafter is that we do conference in some, I don't just mean Tony and I, but that we bring together members of each party, and we would sure love to invite the board when we do that and kind of share back and forth what we have so far. And then I think we'll learn some ways to maybe develop further from that. So I don't really need a budget to do that.
That's what I was assuming this was just going to happen.
I think it's happening and
Yeah.
we're recognizing
Sounds like it.
Yeah.
I have another question, only because I don't know the answer. Are there any continuing education credits required among your staff for the work that they do, and can this satisfy that role if there are?
Right now, I can't off the top of my head see them, their mentorship and some of the things they do, providing continuing education. That said, there are ways to apply for continuing education credits. We do know how to do that because we do it for conferences. And I think I could take that question actually as a suggestion to look into that.
I saw the half-day conference on there, and I'm like, well, if there's an
Mhm.
education component, could we
Mhm.
have it fill some of those hour
Yeah.
requirements? Cool, that's all I have.
Yeah.
Can we make a motion?
Yeah, sorry. I realize that's why you're really looking at me now.
Oh, she wants a motion, yeah.
Wink, wink.
Sweet.
Can do a motion to approve the Academic Health Department agreement with the University of Montana Public School of Health and Community Services, and authorize the vice chair to sign the document.
I would-
At this time, are there any staff questions or comments additional? I just, a comment from me personally, I'm happy to approve this today. I think linkages between the university and local government and business are so important that we're furthering this One Missoula idea. And I think that this just is another step in the way to do this. So I'm happy to do this today. Do we have any public comments on the motion on the floor? Seeing none, all in favor?
Aye.
Opposed? Motion carries.
Thank you. If you could sign it,
I will.
and we'll give it to Tony, and then Tony and the dean, who's also very supportive of some of our bridging efforts, sign, and then we'll get it back to Julie.
We're not Robert Rules of Order, are we? Okay, so
No,
let's say.
Second.
we don't.
It felt like, also, I was like, I almost went into Robert Rules of Order
You don't
motion for
have
a
to
second,
do
while you were doing
seconds.
that, I'm like, oh, okay, and I'm like, wait, we don't need to do that.
It felt like that's what we were doing.
I know, it's hard between different boards.
I'll just sign it when it gets back from you and the dean.
Okay.
Then we'll know it's home.
All right.
Then we'll send you a copy.
Okay.
And then I'll set up a date for our first conference.
All right.
All right, thank you, Tony,
Thank you.
very much.
Thanks,
It's
everyone.
exciting.
Thank you.
So it looks like we are going to be challenged in keeping the TV staying on today. I apologize. We'll see.
Josh's assignment will be to move the mouse So next up on the agenda is to approve a letter of support for accreditation reapplication and authorize the vice chair to sign. Ellen, this is yours.
Thank you. We filled out our application for reaccreditation last Thursday. We're ready to send in, and the last thing they asked for on it was a letter of support from the board to be uploaded. So we're very lucky that you are having this meeting today.
We have a quorum, yeah.
We of course have
Janet.
the old letter, but that's 5 years old and that wouldn't do. So I would request that the board approve Debbie's signature on this on the behalf of the board, letter of support for our reaccreditation effort, and then we will upload it with the application and press send.
Well, I would,
That's a nice task.
yeah, I was just gonna
Oh.
go for it, but.
I was too. So, no, I have
Do it
no
up.
questions. It's great. So I move that we approve the letter of support for the reaccreditation application.
Any staff questions or comments on the motion? Any public questions or comments on the motion on the floor? All those in favor, signal with aye.
Aye.
Opposed? Motion carries.
So Ellen, when will we hear back from these folks?
We don't know. It's kind of open-ended right now because no one has been through the whole reaccreditation process. So there's a little bit of a funnel getting the machinery going. When we do hear back, and assuming they accept our application as it was presented, we then have 8 weeks to upload all the documentation we've been preparing into their system.
Great.
So did they send people out to?
They do on the first accreditation, and I am one of those site visitors, so and so is Cindy Farr. On these reaccreditation, they're trying to do it virtually.
Cheaper.
Yes.
Interesting. Next up is action on a comment letter regarding proposed revisions to Montana Numeric Water Quality Standards, DEQ 7, and authorization for Vice Chair to sign. Todd Seib is here.
Hi,
Hi.
I'm Todd Seib with the Water Quality District. So, yeah, the Water Quality Act of Montana, MCA 75.5, gives the Board of Environmental Review the authority to set and establish water quality standards, numeric standards and narrative standards. So DEQ 7 is the numeric standards for the state. The last time they were updated was 2017, so the 3-year triennial review would be next year. But what's going on now is the Waste Management and Remediation Division has requested a special criteria adoption for these 6 chemicals that are mentioned in the letter. The PFOS, PFOA, dialate, dioxane, iron, and manganese. So the main reason these 6 are being proposed now is because they're either found in Montana or would establish standards that Montana doesn't have that we need to have, either because federal guidelines have been updated or that, sites are currently being remediated and there's no standards for that site, so it would help out that division greatly.
Are those first 2 firefighting compounds?
The PFOA?
Yeah.
That's in part what they've been used
Okay.
for. So, yeah, so the PFOA, OS compounds are basically long chain compounds where all the hydrogens that would normally be on these, attached to these carbons have been replaced with fluorine. And so it's like a surfactant, it's like a Teflon, yeah, non-stick coating. It's been used in waterproofing of clothes, it's been used in cookware, and in firefighting foam, stuff like that.
Usually it's military bases that contribute to that, right, if I remember correctly?
Actually, the biggest contaminations to surface and groundwater have been near the plants that manufacture this stuff.
Okay.
So discharge. They've been voluntarily discontinued in 2015, but they're super persistent. They don't break down in the environment. And so it's estimated that everybody has it in their blood if we were to test our blood. It's one of those great chemicals. So to replace those chemicals, they've come up with Generation X, which are still fluorinated compounds, but arguably, or they might be just as
Generation
bad.
X.
Generation X.
That's me.
So persistent. Those compounds, okay, so if these were adopted, so the 2 we're talking about, those first 2, this would be for groundwater DEQ 7, human health standards, I should say that. These aren't aquatic standards, and they're not necessarily, wouldn't be the same thing as public water supply drinking standards. Those would have to be, that would be a separate adoption, a separate rulemaking process. But right now, public water supplies adopt a lot of the CFRs. But this would be a first step in a good direction. a lot of these are carcinogenic, you know, and different types of have different types of toxic outcomes. The fluorinated compounds have all kinds of crazy results. Like you can get high cholesterol from them, and developmental damage and things like that. But I want to just mention manganese and iron because those usually sound like something that's in our multivitamin. And like, what's going on here, right? I might be able to find a map, but basically the whole state of Montana has high levels of manganese in our groundwater, higher than normal. There's not a primary drinking water standard for manganese. There's a secondary drinking water standard, so for taste and odor and that sort of thing. And that standard is 50 micrograms per liter. What the state is proposing for manganese would be 100 micrograms per liter as a groundwater human health standard. If you look at the state of Montana, I have a map from DEQ, and there are plenty of places that have over 2,000 micrograms per liter. And then locally here, like quasi-locally at a cleanup site at Smurfett Stone, the most recent data from EPA shows levels as high as 50,000 micrograms per liter. And so the 100 micrograms per liter that EPA is proposing right now is not random. The current guideline, federal guideline for human health safety is 400. The problem with that number, the criticism of that number has been that it was based on adult dietary intake. Adults, we have good homeostatic mechanisms for not taking in too much manganese, but infants and children don't have that. And they think that infants and children can absorb as much as 20% of their ingested manganese, whereas we might absorb like 1%. So taking that into account, they've adjusted that 400 number using some standard equations and things to get down to 100. And so that's something that we support. This comments about this rule change or this standard change is due February, I think 8th originally, February 5th or 8th, I can't remember, but is extended to March 25th, next Monday. And there's been a little bit of pushback from industry, specifically on the iron and manganese, because those levels we are seeing higher levels at cleanup sites. At Smurfett, iron, we see 10,000, 12,000 in some wells. At Smurfett, and the level proposed here is 4,000.
Is that because of evaporation ponds, or what? What's the presumed reason for it being so elevated?
So the iron and manganese are thought to be, produced in the waste stream of a pulp plant. But they're not entirely sure actually, like where, if some of them are leaching out of natural soil deposits, or if it's all from bleaching and that sort of thing. But we do know they're high.
Yes.
Exceedingly high. So that's where we stand. So yeah, comments are due the 25th, and there's been a little bit of pushback from industry. So DEQ has proposed doing some more outreach on specifically those two compounds. If they didn't go through this round, though, we would suppose they would go through or be proposed again for the 2020 triennial, standard review. So,
What's the process on this? Like, we send this letter, but what does DEQ do to make these decisions? Is there a hearing?
there is a hearing, and I can review that MAR notice, but there's a Board of Environmental Review hearing, and they take into account comments and make a decision. So that would be.
Is it the kind of thing where you would go and talk?
I think that's an option, but I've never done that. I think like these comments can be submitted orally at the meeting, or in writing, or however you want to support that.
And is there a board at DEQ or a person, or how's the decision ultimately made?
I assume it's the Board of Environmental Review. I mean, it is the Board of Environmental Review. I don't know if, much more beyond who the head of that board is, or.
Just for a reference, what's the manganese level in Missoula city water then, looking at the World Health and EPA?
It's like non-detectable or
Okay.
very low. Yeah, it's not even close to the secondary standard, so.
Okay.
Yeah.
I don't know my industry.
Competing on this, just because I'm curious, really. So,
Yeah.
and do you know who's on the Board of Environmental Review? Is that a governor-appointed thing, or?
Yes,
It is?
it's governor appointed.
And legislature approves.
Yeah, the Senate approves the.
Ah, okay.
appointments.
So do you know what other states have standards that are already in place?
For the PFOA and PFOS, there are a number of states, I actually brought that. And they're all just a little bit different. So I should say in 2009, the EPA had some guidelines for these chemicals, and then they updated them in 2016, so now they're more strict. But so 5 states, Alabama, Arizona, Colorado, Maine, and West Virginia, have adopted these EPA advisories into their state standards.
West Virginia.
And then a number of states have adopted them into their soil screening levels.
And so how do these proposed standards kind of fit with the pattern that is out there in the other 5 states?
So those other 5 states adopted the same
Same
level,
standard.
0.07 micrograms, yep.
What's the proposed level for iron?
For iron, it's 4,000 micrograms per liter. Yeah.
And so in light of, can you just push the mouse real quick?
Too late.
So in light of the ongoing work at Smurfit Stone, we'd like these to come into play for the characterization efforts that are going on there now.
Yes, absolutely. So
That would be great.
if it's not listed as a standard, then they're not in violation of a standard, and so then there's no planning that's required for remediation or cleanup in that.
Given that, would it be of help for other bodies like the BCC to also send a letter? Or would it not?
I don't think it would hurt.
In relation particularly to the manganese at Smurfit, is that what you're,
Exactly,
your
yes.
connection?
Yeah,
That could be done. Can prepare that.
that would be great. Send it to
What,
us.
when are they due again?
Monday.
Oh, I don't think you'd get it through your system by then.
And nobody's
Sorry
here
about
next,
that.
nobody's here next week. either,
Yeah.
so It's all spring
Could
break.
do it.
But the Water Quality District has commented, and I think if
Yeah.
the Board of Health comments, I think that sends a good, strong message.
Yeah.
And if it's the kind of thing, checking with Travis too, but if it's the kind of thing where it would make sense or be helpful to have somebody go speak at this meeting, given that I've never seen this Board of Environmental Quality Review Board meeting, I don't know what.
Board Environmental Review.
Sorry,
Mhm.
no disrespect to them. I don't know if it would make sense to have somebody go there and say, we're doing this thing at Smurfit, and it would really help us out, or not. If you all were to say
We-
that would be a good idea, I think
Yeah, I
one of
mean, we
us
can
would be
talk
into
about that
doing
at the
it.
staff level. It's just kind of logistical, I think.
I mean, given how
Mhm.
important Smurfit
Mhm.
is, if this looks like something to
Yeah.
follow up on. we
Yeah.
would.
What industry categories are are doing pushback? So like, you don't have to say company specifically, but like industry category, is there like a category, it's like automotive repair or energy generation or whatever? Is there an industry that's specifically?
I don't know that,
Okay.
actually, yeah, I have real general information from DEQ.
Okay. Oh, good, so just DEQ just said there's some industry pushback,
Yeah.
okay.
They did say there was.
I was just wondering if it's critical industry or not critical industry.
Right.
Just on the logistical front with BER, I don't think we've been over with BER for a while. Probably the air folks more recently, but they used to have and may still have like a day-and-a-half agenda because they pull in from all over the
Sure.
state. And of course, there's been times it's absolutely critical to be there. And there's other times if it's possible to be there. So I think we'd have to look at it logistically. If you can figure out truly when the staff would need to be there and to do that
And how critical it is, I have no idea.
Yeah.
If you think, oh, this is gonna sail through and it's not a big deal, then we shouldn't put any effort towards it. If
I
it's gonna be
wouldn't-
highly
I
contentious, then we should.
wouldn't guess that at least the part that's being pushed back on would just sail through. I wouldn't guess that. I mean, if I were betting, I wouldn't bet that.
That it would sail through.
Would not.
No, would not.
I wouldn't bet on that.
That it's that they can push the delay for a year and
Yeah.
gather more.
So then maybe we
input.
do figure out how we can apply pressure.
All the
Yeah.
numbers seem legit to me, so, I mean, looking at them, it doesn't seem out of line. I'd just be interested in what industry was worried about those numbers.
Yeah,
I'm guessing that it's mining industry, particularly related to iron and manganese.
Yeah.
Especially manganese.
Yeah. I guess if there's a big manganese mine and you're spelling it everywhere, it makes sense.
It's just in everything here.
Yeah.
Anything else? Are you guys ready?
All right.
Good. I would move we sign the letter.
Okay, any other board or staff comments on the motion? Any public comments on the motion on the floor? All those in favor signal with aye.
Aye.
Opposed? Motion carries.
Thank you.
What's that?
And
Next
that was
up-
our last action item, right?
Yes. Next up on the agenda, monthly updates on strategic priorities. First up is section 3, assets, internal capacity and support systems, finance. Goal 2, secure new grant funds to support maternal child health endeavors. Objective 2, submit proposal to Montana Healthcare Foundation and evaluate Missoula Foster Child Health Partnership. And we have Sarah here.
Hello. I'm Sarah, I'm the Director of Health Services, and this is a quick update on strategic priorities. I don't need to repeat what Debbie just said as the title. But the first objective we had was to submit a proposal to Pacific Source to expand Welcome Home Baby, which was our universal home visiting pilot, by August 15th of last year, and we did do that, and we obtained support from both hospitals, and we did submit the grant. And unfortunately, we did not get this particular grant. Ellen and I had a conversation with the Pacific Source to get feedback on how to better prepare that grant, and we're looking at other items and options to move forward with something slightly different. So, but that part of the objective is complete. With more exciting news, Objective 2, submit the proposal to the Montana Healthcare Foundation to evaluate our Missoula Foster Child Health Partnership by the 4th of October last year. We formed a team, including DPHHS Child and Family Services Division, and using Nikki Grossberg as our contact. She's the assistant deputy.
Assistant deputy,
Is that right?
of Child and Family Services for DPHHS.
Yes. She used to be our regional director here, so she's very, very familiar with our Missoula Foster Child Health Program, and so she's a great liaison to have in that position and connection to move forward with this project. We did identify a primary evaluator and have been using Tricia Miller, and we found her through the University of Montana through Ellen's connections. And so she helped us with our initial grant proposal because she had a passion and interest with the population of foster child health, and then we ended up just finishing signing her contract for the next 2 years for her services to help us develop the evaluation design. And so then we did submit that proposal, and we did receive the funding for a 2-year grant amount to evaluate our foster child health program. And that is super exciting because we've had one evaluation already back in 2014, somewhere around there, by Dr. Bart Klicka when he was at the university. And this will then take that to the next step where we're looking at both some qualitative and quantitative data with a comparison county, and we're using Lewis and Clark as the identified county where they do not have a foster child health program like ours. And so part of the qualitative piece would be to do some survey responses that we're currently in the process of developing, looking at feedback from the child protection service workers, the foster parents, and then the medical providers involved with them, and then as well as Missoula County, and how that compares, with having a public health nurse involved in that process of caring for those foster kids versus not. And then the next step is working on our outcomes that we're identifying of what we want to track, what we're currently tracking in Missoula County and have been as far as health outcomes, and if we think that our public health nurse interventions help make positive impacts on those outcomes. So we're still very much in the process of ironing out those things and working on getting the IRB submitted, but hopefully going to start the evaluation process within the next couple of months. So very exciting news.
Very exciting.
Yeah, it's really cool.
Yeah, with this, we're hoping that it will help move us up that evidence-based ladder as being recognized as the promising practice and onward, because the closer we get to that evidence-based label, the more likely you can replicate your program, the more likely you'll be able to receive funding for your program. So,
You said be recognized, who would be doing the recognition?
well,
Or do you mean sort of general
There's different
recognition?
ways to be
Yeah.
recognized. The one you just described is moving up through the
evidence-based
research ladder for evidence-based, so just moving to a control study. We're already a promising practice from our first one. This will move us up higher.
Is this published papers then? Is that what you mean?
And having it published, that's how
Okay.
we'd be going.
So
But
gotcha.
there's also another form of recognition, and that's through the National Association of City County Health Departments for model practices. And we've submitted for that as well.
So on the first one, is there a third party who's doing some rankings or something like that?
You know, there's not like one third party that does that for any type of this type of proving up. There is, however, what's been put together because of the Affordable Care Act. There is I don't know if it's one party or a group of parties or whatever, but there's a list of acceptable evidence-based home visiting programs that you must use if you happen to be using Affordable Care Act money for home visiting. But there isn't one that we're aware of for foster children. And one of the bills is actually going to be up next, I think it's up next week, is nationally, the money that comes down for foster children is redesigning how they're going to spend that money so it's used for evidence-based programs and also for more preventive ones. This particular program, because these kids are already in foster care, wouldn't immediately qualify for that, but it may qualify for other pots of money by having at least a control research study done on it. So,
yeah, and we'll find out April 30th if we are going to be recognized through NACHO as a model practice. So that's coming down the pipe.
Yeah, that's good.
That's great.
Yeah, very
Goodbye.
exciting news. Thank you.
thank you.
Questions? Thanks.
Okay, thank you, Sarah. Next up on strategic priorities updates, Section 2, environmental conditions, Goal 7, reduce the amount of nitrate discharge from wastewater treatment and disposal systems in CD with community to improve groundwater quality in areas that have elevated nitrate levels.
Sorry, it's so
Jim
wordy.
Robbins here. No, it's great.
Big job.
Yeah, and we're not doing it on our own or directly. We play more of a supportive role in this whole thing, but as the board's aware, there's a sewer project in motion up in the Missoula Lake area. Because we have groundwater contamination due to septic systems, nitrate is the main concern there. We've had some wells exceed the allowable standards. So, you know, some of our strategic goals address that, and we'll give you an update on that. Just to summarize, we are ahead of schedule on these. And the sewer project is moving along. It's been a little bit touch and go, or it was, I guess, last couple of years. Former board member of yours, Jean Curtis, is now the managing person responsible for doing that, and she's been thus far very proficient at that. Seems like she's getting the job done. So yeah, our first goal, or our first objective, is to sort of quantify the load of nitrate that's being currently discharged by septic systems up there, and compare that to what this treatment plant will reduce that to. It's based on water flow estimates from the water district up there. And I have to disclaim, these are estimates, right? That it's not an exact science, because different waste streams will have different concentrations of nitrogen in the wastewater. And also, you know, quantity of wastewater being generated does vary from parcel to parcel. So, estimates. So our first objective was to, or our first action within this objective was to determine the area to evaluate. The sewer project has been broken into 4 phases, and right now phase 1 is what's being focused on funding and planning wise. So that's what we focused our look at. in terms of this is just strictly to phase one. So based on the numbers being generated by the design reports right now, there is just shy of 175 lots being connected to the wastewater treatment plant in phase one. Of course, it's a mix of residential versus commercial. But using that data, we approximate generally about 30,000 gallons per day of wastewater currently being generated in phase one. So using what we know about typical concentrations of nitrate in wastewater, we calculate that that's about 12 pounds per day of nitrate being discharged into the groundwater there. And of course, it's relevant to remember that hydrogeologically, this area of Sealy doesn't have a lot of dilution happening. So, you know, that's why we're seeing the nitrate issue in the first place right there. But DEQ has issued a discharge permit for the wastewater treatment plant and set the maximum allowable nitrate concentration in the discharge at 7.5 milligrams per liter, compared to what is currently estimated at about 50 milligrams per liter. So it's an 85% reduction, and that's their maximum amount that they can discharge. The engineering firms and the industry itself claims that the actual performance of this treatment plant is better than that. So, so taking that 12 pounds per day, which is, I did some research on fertilizers. I'm not a gardening expert, but that's 12 pounds per day of nitrogen generally is about a half acre to an acre worth of fertilizer for lawn applications. So into groundwater, if 12 pounds doesn't sound like a lot, but 365 days per year, reducing that by 85% is huge in terms of what we do. And so that was our first objective, was to sort of quantify what is this treatment plant going to do for this resource up here. And the second is sort of just to continue to play a support and advocacy role in this whole process by attending all the sewer board meetings regularly and being available to clarify issues, questions that they have come up at those meetings. So we've been doing that, and we'll continue to do that. The other thing is we're just trying to be savvy about how we can play a role in informing the public as to what the issue is and what the concerns are and what the solution is. And so, we've responded to some public inquiries in the newspaper and just in our department and at the board meetings that we feel has helped clarify things as things go forward. We're also working on looking into some funding avenues that could possibly, we're not quite sure yet if it's going to work, but could possibly play a role in helping some of the low-income residents up in Sealy afford this, because it is expensive. So that's something that we want to continue looking at, just to see if we can improve that. And the third part of that was to keep our eyes and our understanding of our regulatory role in this, just sharpened, because should the sewer project not become, right? If it should falter somehow, we do have a regulatory responsibility to address this issue. So right now we're hoping to not have to come at it from that regard, because the sewer really is the solution. But it is on our action list for things to keep in mind.
Questions about monitoring nitrates in the lake? Do you know where we're at? What types of things what's been the change over the last handful of years, and what would you anticipate after the sewer?
Sure. The lake does show signs of nutrient loading in terms of algal growth and reduced oxygen, things like that. I was actually told recently that they've been dredging the lake of its vegetation in certain bays midsummer, because it's actually, it's booming so much. And so the sewer project's going to definitely decrease the load, so I think we could assume that over time, we'll start to see some of those impacts improve as well.
Is the sewer plant design, is it all chemical treatment, or is there a biological component? Do you, I mean,
It's biological.
so it's all
Yeah.
biological component? So like,
Yeah.
okay.
Yeah, sequencing batch reactor, and it'll be located actually outside of our county, which I think is interesting to
Really?
note. Yeah, I mean, the collection system obviously takes it all out of Sealy Lake and delivers it just over the county line into Powell County
It's kind of a ways up there, isn't
on
it?
some state land. It's
No,
quite
it's not that far. I mean, the line is really close.
Yeah.
Good design.
Double arrows.
Right.
Yeah, double arrows almost on the Powell County line.
Okay.
Yeah.
Oh, yeah, the county line's pretty close, yeah.
I thought it was further up for some reason.
The Lake County line is
The,
farther up.
oh, the Lake County, like, that's what I'm
You're
thinking.
thinking, yeah, Powell.
Powell.
Yeah, Powell's just right there, yeah,
Yeah,
I see
yeah.
now, yeah. Now it makes sense. I was like, that's way up there, like almost Condon, but now I understand.
Yeah. Are phases 2, 3, and 4 of the sewer, the ultimate sewerage plan similar in size to phase 1? In terms of 175 units?
Number
or-
of connections.
Mhm.
I believe that that phase 1 encompasses most of the most densely developed areas, so I don't know 100% for sure, but I would venture to say that there are less lots being connected in the future phases. But, the conversation's ongoing about annexing certain areas in, or what type of development, subdivision opportunities and development opportunities this will create. So, I think the other phases will have a lot of new development as a result of the infrastructure going in.
And are the grant funds that you're looking for contributions to the lot owners to the mains project, or for service connections?
Well, we're looking at all options right now, but most recently, we've been looking at some DNRC funding packages that might not exactly fit this application. We're really in the preliminary stages of kind of looking into that, but it's definitely something that's on the radar. And because the actual connection costs are included in other words, the homeowners aren't going to be on the hook for paying for connection to the sewer. It'll all be
It's all
as part of the
project.
user
Okay.
fees, the monthly user fees. So maybe some of the funding help could come in assistance programs towards those monthly fees.
So they don't pay anything but just a monthly fee, there's no additional new tax or something?
That's my understanding, yeah.
And you have a guess on what those monthly fees might be?
They're estimated for phase 1 right now to be about $90 per month, which is high, right?
Because we are planning to fund it. I don't know how they do.
Any other questions, Bridget?
Are there any air quality impacts from the sequencing batch reactor out there? So I'm assuming it's bubbled oxygen through the whole process, and so, I mean, there's NOx, right, off that whole aspect? Once you do the oxidation?
I haven't seen.
I mean, 30 pounds a day actually isn't that much, but
Yeah.
statistically, but I mean, I was just wondering if it hits permit thresholds as you start lining people up, because once you break 10 tons, right, of NOx or SOx, you have to start getting air quality permits. That's my
Yeah.
remembrance.
And I don't.
I don't know,
think
I'm just
there
interested,
is-
but not important right now, but I'd be,
Yeah.
since Sealy Lake had other air pollution problems, might be worthwhile to pay
Yeah.
attention to the other ones that could occur.
Mhm.
And it-
Sure.
yeah.
Yeah, it's a little bit outside of where the air seems to stagnate, is my understanding. That's an interesting point.
I'm more familiar with the anaerobic digestion side, so that was gonna be like a flare, and then I realized it's just oxidative, so never
Yeah.
mind.
If it goes through and development, allows development, of course, to
Yeah.
grow, then of course we'll have air quality implications.
Yeah, I was doing the math in my head of 30 pounds of nitrogen, if it all went to NOx and you added the weight to it, and this, you could start getting up closer to that 10 tons per year
Yeah.
discharge levels based on that whole thing, based off the system, so.
But then again, it would be in Powell County.
Yeah, that's their problem. I'm not worried about it.
It's
Fair.
being recorded.
Fair.
Our friends in Powell County. Okay, thank you.
Thank you.
Keep up the good work.
Next up is an exercise in board prep for Measles Outbreak.
Sit next to me.
This will be exciting.
Something to disclose. That'd be my cough right now. That's just kidding. As I'm sitting here coughing, I'm like, now we're gonna do an N=1 experiment and see how quickly everyone gets sick and what's the vaccination
It
rate.
will spiral, but it's not.
I don't know what I have. Other than my nephew coughed on me and then I was sick 2 days later, so.
Trying to pinpoint the culprit who gave this to me.
I can identify my nephew in my
I
case.
think I know her.
To get to the slideshow part. Slideshow.
First, I want to recognize the very impromptu planning team that helped me put this together. This is being presented today in ways that we hope will first provide you some basis and then allow some interaction on how the department's preparing for measles, and with a particular focus on what board authorities exist for some of the police power controls that may be used through the quarantine and isolation policy, to understand that terminology. A little bit of ask and answer. We do plan this to be long. Usually we say we're 5 minutes and we go to 20. We are trying to stay in 30 minutes. Dr. Steger, after your journal article, pointed out to me that it would be really helpful if the had a chance to experience the onset of measles and all those questions
Thank you.
before it happened. Because as we were talking last month, we were trying to emphasize how explosive it can be, that the growth is it's highly contagious.
So to set the stage, what's the estimated vaccine compliance in Missoula County?
Yeah, that's in the slides, so we'll
Excellent.
get to some of that. I don't have all of that, but Colleen. And so to do that, we did a measles tabletop with community partners just over a year ago, and that freshened a lot of us up and worried us and so on and so forth. And then with the current events in the Northwest and elsewhere in the country, we've been more on alert. But the team that you see sitting right next to me, Anna Conley, joined us, and Sarah Heineman, and Colleen Morris, and Cindy Farr, and Leah Hickey. So their usual roles, we're not going to go into right now because they joined this preparation as if we were in an incident command role. So once we know that we have to move fast, we're going to go into an incident command role. And in that role, I would be the liaison officer. We just assigned these. We could change these, but we already had a measles planning meeting, so we stuck with this. I would be the liaison officer who talks to the board, talks to the city, talks to the county, talks to the hospitals, and so on and so forth, to make sure that we're all on the same page in response mode. Anna is and would continue to be our attorney, we would hope.
Unless she gets measles.
It's an outbreak, I'm out.
She gets sick.
In a real tabletop, you do take people out, throughout it's a fun thing to do, is, you just lost your incident commander. So, speaking of which, our incident commander then would be Cindy Farr, who, among her other duties, oversees the infectious disease control. Our operations chief would be Sarah Heineman, and that's usually the biggest part of your incident command, and many things fall under operations. And what the one branch that we staffed so far under operations would be our vaccine branch, and that is under our current clinic nurse manager for vaccination, and so that's Colleen. And then Leah Hickey, right here on the end, is our public health emergency preparedness coordinator. And if that isn't enough to do for this exercise, we made her the public information officer. So they will join in. If I say something wrong, you have a question that I want to defer to them. And then there's a point at the end of this where they'll just say, okay, we focused on board authorities, but let's just give you each a 1 minute, 2 minute briefing on what else we're doing.
Who's interface with law enforcement then?
who's interfaced with law
Yeah, so who'd be in
enforcement?
charge of
The
interfacing
hub-
with law
It
enforcement?
depends. If we're just trying to talk to them agency to agency, like are your people protected, understand what we're doing, you know, people can't congregate in an area, for example.
I see the word quarantine here,
That
so
would be,
usually.
we'll get to that. That would be the liaison officer. If we're really going to work out some sort of plan of attack or issue an order or do a joint command, then that actually would go through the incident commander.
Okay.
And then some things can only happen by the health officer. So often when we've had outbreaks, I've been the incident commander. And often I haven't been in this particular setup. So I'm not going to be.
And so media is with Leah, not with you?
Right.
Media outreach, okay. Check. Okay.
They all oversee things, you know, if it gets big enough, they all have a team. But, so they're sitting there ready for it, to catch any mistakes I made last night, which I'm sure there are many, and anything like that. But we didn't have time to prepare a whole tabletop exercise. So we're gonna do more presenting on the first part, and then jump in. So, the goals of today are to go do some definition of terms in communicable disease control, particularly again as they relate to things like what is quarantine, what is isolation. To touch on as much as possible the health board and health officer duties and authorities. So you have both duties and authorities that come into play, some of which you've already put into policy, and that is why your quarantine and isolation policy was in your packet. You looked at it again last month. Okay. To learn a little bit more about measles, what we call Measles 101, and MMR, measles, mumps, and rubella vaccination. The use of the communicable disease control measures. There's a lot of communicable disease control measures. I messed around with the wording on this, but it just got too long. We really want to look at, for most of this exercise, the duties and authorities. And some of those have some medical measures and control measures, and some have some messaging control measures. But we want to look for your experience at the police powers. So if we came to you and said, whoa, we're trying to do such and such, and it's, you know, we're not sure we should do it, we're not sure, and we wanted to consult the board, then you would have enough background to understand the difference between quarantine and isolation, or to know that you have powers and duties as a board. And then just the briefest, we are not going to jump into incident command and learn incident command, but just to understand that these folks here are sitting there with different titles soon after this scenario starts. Definition of terms. When I don't mean to be not sensitive, but when we're talking and sitting around a table and we say a case or the case or 10 cases, we are referring to a person who has the contagious and reportable disease. So a case can be someone who, the lab has already come through and confirmed it. It can be someone that's suspect or presumed because of their contact with someone who had lab confirmed. We don't have to wait for confirmation and shouldn't wait for confirmation on some communicable diseases because we lose our opportunities to prevent spread. So that gets a little tricky, and that's kind of how we're setting this
And
up.
you sent it around last year when we were talking about the quarantine procedures, but if someone could resend to the board, since Josh wasn't here, the list of reportable diseases,
Sure.
that would be super awesome
We
just to send
actually have
around,
a
so you can
mouse
actually.
pad that has the reportable.
Yeah, so there's a list of reportable diseases at the yeah.
A contact is the person who was exposed to the infectious or contagious disease. The key here is, that doesn't mean they knew them or they, in a lot of diseases, walked past them. It's someone who was exposed in a way that that particular mode of transmission for that disease could actually infect them. Okay, but contacts, and what we do with contacts is, with measles in particular, we might have a whole classroom of contacts. The first thing we're going to do is find out which have their MMR on board. And then all of a sudden, our number of contacts to deal with goes down, okay, in terms of follow-up. You have a contagious or an infectious period, same thing. There's a period of time in which the person with the disease, and they may not know they have the disease yet, is infectious or contagious. And we'll see in a minute with measles, part of the time they don't know they have it, infectious, and part of the time they do know they have it. So, and it's different with every disease. But in terms of your police powers are really triggered by contagion. Isolation is actually when you have a case, you know you've got the disease, you've got the symptoms, it's at least presumptive, you may be waiting for a lab confirmation of some sort. But because of the way that disease is spread, that person is isolated. And that gets mixed up with their quarantine, they're isolated, they're whatever. But technically, they are isolated, and you'll see these definitions in your Q&I policy. So this is a patient that, I think this patient has SARS or something. That's where that picture's from. And if a person's in the hospital, they're gonna know how to isolate them, but if you're sending someone home, yeah, you
Well,
know.
Missoula has one of 5 hospital-based isolation wards in the US, right? I do
Not
read.
isolation,
Well-
it's for,
It's for the level 4 biohazard.
Yeah, level 4, yeah, but
And
we have
that's-
people at the hospital trained for this kind of stuff,
That's
my
yeah.
daughter is trained for it.
Yeah, so there you go. I was like, I knew I remembered Missoula's.
Quarantine, and this is an old picture, because you don't really, we don't use quarantine in the way that was done in the old days. In fact, we talk more about exclusion, which is a type of quarantine. And really what you're doing is you've got someone that was exposed and is truly a contact. They could be incubating this disease. They could be contagious with this disease based on your timeline. And they just don't have symptoms yet, but they're contagious, or possibly if they were infected. So that's quarantine. And quarantine in the modern age, especially with all the different things that we can do with vaccines and treatments and so forth, luckily we don't see it as much. But we do see it, and we do use it as an exclusion. And we will sometimes say, until your brother's lab test comes back, we want you kids to stay at home, till you get full information. There's an awful lot of due process and restriction of liberties to consider when you're looking at quarantine. When someone's sick and you know they've got the disease, it's a little easier for the state to push and say, we know you've got the disease, you need to stay put. If somebody who doesn't have the disease yet and you think they could get it, I think that's a little harder. I'm not trying to speak for Anna, but my teaching, that's a lot harder to say your liberties need to be tamped down. So,
Well, and how it's enforced is interesting too, because I remember that nurse who got exposed to Ebola, she went out and did stuff even though she was supposed to be under it, just went and did it anyways. And I don't know if they ever exercised their police
I
powers to
actually
make her
have
stay
a
put.
completely different side to that story.
Yeah.
We should discuss that.
Yeah.
She shouldn't have been isolated, quarantined in the first place.
Probably, but.
Yeah, but Chris Christie thought that was a good picture. I used to use that for my quarantine picture
Yeah.
because it was so, the only modern picture. So measles. This is purportedly a mom sitting with a kid in a waiting room with a mask on the kid's face because she correctly called ahead. There's nobody else in the waiting room. And they said rash, fever, child vaccinated, or maybe child too young to be vaccinated. They said, whoa, let's clear our waiting room. Let's put a mask on you. And okay, so measles is highly, highly infectious. So when I wrote to Dr. Stenger, when I realized he wasn't going to be here, he said, what is the main point you want to get across? He said, I have two. One is you have to move so fast. You have to move so fast to try to control this through vaccination of contacts. Number two is because of the exclusion periods for a healthcare worker who's exposed and susceptible, you can pretty much shut down a healthcare facility. Or really hurt their staffing if you're not vaccinated or prepared for exposure. So it's airborne, and in fact its incubation period is from seven days from the time the person was exposed to measles. They may get their first set of symptoms at earliest 7 days after, and as long as 21 days after. So you've got a real waiting period. If you were looking at quarantine, you've got a long waiting period. Contagious, excuse me, I jumped ahead of myself. It's infectious, we usually say infectious, the public generally calls it contagious, so I switched between both words here, but with measles, it can be contagious for 4 days before the rash appears, and you're contagious for about 4 days after. Measles is so contagious and so that after someone who has measles has been in an area, that area, anyone who was in that area, doesn't matter how close they were sitting to them, or enters that area, let's say it's an exam room or a waiting room, for the next 2 hours after the child leaves, can be infected. That's how catchy it is.
Can I just add one thing? So the one thing that is not super clear on the slide is that most of the time, people are still going about their business. They think they have a cold, they're running a fever, they have cold symptoms for 4 days before they get the rash. So they're doing whatever it is that they normally do, and then when they get the rash, that's when people start getting suspicious.
And then we have to go backwards and forwards at the same
Right.
time for protection.
Sure.
So just point that out.
Spewing measles for 4 days.
And walking around the field for a while. So measles is vaccine preventable. We have some slides, we'll talk about that. And it also, you can stop a case developing if you give the vaccine within 72 hours of exposure. So we don't go over every bit of this, but this kind of overlaps the incubation period, the symptomatic period, the infectious period, you know, another way you use it, for measles. And day 0, doctor calls and says, you know, I've got a kid in here with a fever, they're not vaccinated or they're too young to be vaccinated, I don't like this rash, and, you know, we want to call at that point so that we can start moving.
Does everyone develop a rash?
Mhm.
Okay.
I mean, I suppose you can have some very strange cases on anything, but in fact, the rash starts around the hairline and then moves down. But most people haven't seen it, and most practitioners today haven't seen it, so. And there's earlier symptoms, but most young practitioners haven't seen those symptoms either, they occur in the mouth. I really want to emphasize the strength of the MMR vaccine. For individual protection, that first dose is going to be 93% effective. That's high. There are vaccines that are not that high. That second or booster dose, it is 97% effective. It is a good vaccine for effectiveness. For population protection, depending on how you define your population, whether it's county, your daycare, your school building, your family, whatever, you have to have at least 93, better 95% of that population that may be exposed protected, or you're going to have an outbreak of some size. In Missoula County, our 2-year-old, and I got this off your slide, Colleen, so if I have it wrong. So a 2-year-old would have just the one on board. And ours came in 2018, I believe it was, at 90.5.
2017.
90.5%. I don't have the county one for the kindergarten entry, but they should have 2 on board, so the Montana figure is 93.2%. So we're hovering at best, if you look at the county, if you have a school or a daycare with a certain pocket that's lower, you're going to have an outbreak. These are the most difficult and silver lining aspects of the measles outbreak. This is why speed and focus is so important. Because it's so highly contagious, one person could, if they exposed 10 susceptible people, so unimmunized or not fully immunized, 9 of those would likely get measles. So the exponential, or the R factor of it is
You say that
tremendous.
again? Just wanna make sure.
If one person with measles in the infectious
Yeah.
stage was put in the room with 10 unvaccinated people,
Unvaccinated.
9 of them would get measles, if they were totally unvaccinated. The next very unique aspect is you have a 72-hour time frame from the time the person was exposed to get MMR into them. So this protective vaccine is used for what we call post-exposure prophylaxis. It's like almost like a treatment oh, you were exposed, we're getting, now, in a lot of things, we don't have that. But when you find out the kids in school, and they were in school 3 days ago, and they got the rash today, that time clock for those kids 3 days ago is already running. So that's why focus is, we want to focus on the people that we know are exposed, not everyone that now thinks they want to get their measles shot, and that's going to be tricky. This is the complicating factor number 3 for measles in the healthcare setting, and that is even if a healthcare provider accepts the post-exposure prophylaxis. Let me back up. The kid was exposed in school. We got the post-exposure measles shot within 72 hours. Kid goes back to school. Kid goes back to school. Kid is good. There's no other like police powers or quarantines or anything we have to do. And not everybody wants to do that, but the healthcare provider, even if the healthcare provider, so not fully vaccinated, gets exposed, we offer the post-exposure prophylaxis. That healthcare provider still, by guidance, is not supposed to go back into a healthcare setting for 21 days. So you can see how, kid comes in, they're in the waiting room, and next thing you know. So we want to protect the, oh, I love this nurse. This is our infectious disease nurse. No, it's not, but it's one of them. So we're going to put a typical scenario here. And technically speaking, one measles case is technically an outbreak because we don't have measles endemically. So once you go above what you usually have, which is 0, you've got an outbreak. So a measles outbreak scenario, we're not in incident command mode, we're doing our usual job here. And our infectious disease nurse gets, and she's grateful to get, she doesn't look grateful, but she's grateful to get a call from a doctor, healthcare provider, and say, I just sent a kid home and I just sent a lab into the state because I'm highly suspicious that this child has measles, okay? The child is not vaccinated. We always want to get the record in front of us, but we take that report. Lab was sent in, the child was sent home. So that nurse does an interview. What are the couple of key questions she asks?
Is that child in daycare or school? Do they have other siblings in the household? Where have y'all been for the last 4 or 5 days?
And is the family vaccinated?
Yeah, is the family vaccinated?
Okay. So what we're going to do now is while our nurse is gathering that information, Anna's going to talk to you about the powers that may come into play of the duties.
This is the, can I see?
Yeah, would you want to sit over here? Sure, and run through it.
This is the austere version of the PowerPoint. There's no graphics, there's no color, there are no pictures.
But you have handouts in front of you to help you later.
Yeah, so when Ellen asked me to take a look at this piece of it, I just put together a packet of what I understand to be sort of a comprehensive packet of the existing laws and regulations, so we would have it all in one place for future use. So it's not great for a PowerPoint. I think I'm violating every PowerPoint rule there is with this presentation. So basically, I'm just going to talk about 2 things, your powers and Ellen and the department's powers. So board powers. When you think about board powers, you always want to look at this statute, 52116. This is the statute in state law that outlines what this board can do. And you can see that it's very clear that 116 specifically references that you can identify, assess, prevent, and ameliorate conditions of public health importance through isolation and quarantine measures. So that's something that you're specifically granted authority to do under state law. There are other aspects of your authority under 116 that also possibly kick in during this scenario, including this catch-all at the bottom. Some other aspects of 116 that might kick in would be that this board is required to protect the health from the introduction and spread of communicable disease or other conditions of public health importance, and that you're specifically authorized to adopt regulations, which you have, that don't conflict with other state laws and rules from BPHHS to control communicable diseases. So That's where state law outlines your powers. And then administrative rules enacted by DPHHS also outline that you have the power to adopt rules that, as long as they're as stringent as the administrative rules and they don't conflict with them. There's quite a lot more in the regs about the health officer's powers, but I think that there's generally a sense that the health officer is acting under regulations or policies that the health boards have enacted under their powers, so it's sort of a mutually assisted relationship. Also, I think there's an assumption in state law and in the regs that there's going to be interaction with DPHHS and potentially other levels of government if there is an outbreak or if there is something that has occurred. So where you guys are all laid out, your powers are laid out in 116, the health officer's powers are laid out in 118. So this is sort of the go-to statute for understanding the officer's powers. And again, you see that it's pretty explicit, much more explicit than we see a lot of laws out there, that the health officer can take steps to limit contact between people in order to protect the public health from imminent threats and establish and maintain quarantine and isolation measures as adopted by the board.
Like, you could shut down all the schools if there's an issue.
You could.
You could say no one can congregate at a mall, right? Like, you could be like, shut all this stuff down, don't have these people congregate.
Ultimately could do that, of course, that's not where we would probably start, but.
Not for measles, but.
And you're right on the money, because the administrative rules actually lay out a lot more specifics about what those general powers in 118 look like. So they enable a health officer to restrict employment with regard to daycare, with regard to caring for elderly people. They allow you to restrict food handling.
Typhoid Mary, right?
Attending or residing in congregate settings can also be subject to restrictions and exclusions. Also, there's specific issues with regard to if someone dies and what their funeral looks like if they die of a communicable disease. So that's some of the specific powers that the administrative rules lay out. And then there are, there's the power for the health officer to restrict travel to some extent, unless the person is being admitted to a hospital and there's adequate precautions. Then we have a very specific regulation with regard to quarantine, which allows it as long as there's some due process with regard to notice that's occurring. And in fact, you see that word shall. This is an interesting thing about these regulations. The health officer is required to do these things vis-a-vis DPHHS. And so how I interpret this is I must do this, therefore I have the authority to do this, right? So it's sort of the same, two sides of the same coin when you're reading these administrative regulations.
So I have a question then I've talked to a lot of lawyers today, so I'm in a legal questioning mood. So if we do not do an industry standard, or I guess it's not industry, if we do not do a public health standard thing for the scenario, like the CDC says in this scenario we should do this and we don't do it, are we legally responsible for not actually doing it, either criminally or civilly?
That's a good question. I don't see remedies for failure to comply with these regulations as set forth in the administrative rules.
Okay.
We have the department many years ago was sued over some TB exposures that resulted in conversions, and they were subtle, but they were on their way, and those were civil suits.
I was going to say, I can think of a number of civil suit scenarios, but I don't really want to get into those right now.
No, it was more of a, hey, okay, now that I understand that we shall do this, that means you have to.
Right.
What if you don't do it, you're supposed to? Yeah.
I'm sure that you would pay some type of consequence.
Yeah.
That's all we're going to say.
That's how it always seems to go, isn't it?
Then we have 308, which is very specific to isolation, sets forth the duty to isolate in certain situations. And then also gives the right to inspect the place of isolation to make sure that the person is actually being adequately isolated. Again, with some written notice and due process requirements. I don't want to get too much into this because this is more of a duty that the health officer must make sure that a specimen is provided to the Department of Health and Human Services when there is a suspected case. Then this one is really broad, the investigation and control duty or power, however you want to look at it, in 314. It requires that a health officer immediately after being notified of a case, which we've had defined for us, or an outbreak, must investigate and take whatever steps are necessary to prevent transmission of the disease. And then there's further steps that the health officer must take if the health officer determines that the situation, the disease, or the circumstances are warranted, which would include verifying the diagnosis and determining the source and possible transmission. And then how the administrative rules used to work is that for every reportable communicable disease, they had applicable rules. But how they've done that is they've repealed all of those and they've appointed local health departments to the Control of Communicable Disease Manual, which is put out and updated every couple of years. And they basically directed health officers to do what that manual tells you to do for the specific type of outbreak that you're having. So this requires that the health officer follow that manual. So for example, the manual has very specific measles steps that are laid out, and those are the steps that would need to be taken.
I think you guys provided a digital copy when we went through the whole quarantine stuff last summer, or at least links to it, because I read the whole manual.
A digital
So,
copy of the CCDM?
yeah. Either that or you
It
guys
is
linked to it.
digital now.
Yeah, I read the whole thing, so it's
Yeah.
like, it's not exciting, but.
Do you sleep?
No, not very well.
Then there's a requirement, if it looks like a significant outbreak that's going to be going outside of the county, that we cooperate with out-of-county jurisdictions. There's a very specific allowance for limiting congregations that we saw in state law. Then there's these measles-specific references. As I mentioned, the administrative rules talk about the disease manual, and in a couple of different places refer the health officers and departments to doing whatever the manual tells them to do. Then I also just wanted to mention, one question that comes up is, well, what if we have all these great powers, but the person who we say to isolate says, no, I won't be isolated?
That was the question I was going to ask.
Right.
I'll just sit quiet.
And, that is a question that is where you start to make sure that council is involved and other law enforcement is involved. Title 50 does require that law enforcement officers cooperate with public health officials. So, and actually it finds them guilty of a misdemeanor if they refuse to cooperate. It also makes it a misdemeanor to not cooperate with a public health official. So we do have the ability to rely on law enforcement if necessary, and depending on sort of the level that we're trying to escalate to, you also have the opportunity to involve a court with an emergency type of petition or something like that if you wanted to ensure that you were complying with any due process or other rights that the people who are potentially impacted might have. Any questions?
Just
Lots, but yeah.
I'm just kind of moved by the degree to which a person's life would be affected if they were asked to comply with these things. Things that most people take for granted, like freedom of movement and association, would really be stripped of them.
Absolutely.
Quickly.
And I think in my mind, it helps me to understand what quarantine is, where, you don't have to be quarantined in a hospital, you could be quarantined at your home. But it is, a significant restriction on liberty, and it is in a state that really values that. And so it is something that has to be done, in a very specific way. And it's also so important that this be talked about right now when we can sit and calmly talk about it, because you can kind of get a framework in mind for how to move forward if there is a situation.
Are there any public mechanisms for accounting for the loss of income someone may endure due to something like this, where they can say, because of the public, the greater we, I was prohibited from earning an income, which has caused me all this.
In Canada, they are, and they did employ them during SARS.
In the US, there's actually counter things too, so if you show up to work sick and get your coworkers sick, in theory, if you were under quarantine order, they could sue you in civil court for for actually exposing them to it. So it actually almost goes the other way.
Yeah, I'm not familiar with any mechanisms to provide lost income for those who might be quarantined or isolated.
Depending on the person, it could be a really big deal.
So my bigger concern for the Board of Health and the staff here is the cooperation with the police, because unlike lots of other states, this state is heavily armed. And we talked about this when we were talking about quarantine before, is I think having our interface, especially in any kind of quarantine situation, or, hey, we'd like you to get vaccinated or whatever, you're gonna have health officials rolling up, I think having interface with our police departments is incredibly important, especially in rural Missoula County, where it's probably more likely there's less vaccine compliance and we're gonna have to go talk to people. I think understanding that's gonna be super important, because the chances of having someone pull a weapon on some of our staff is much more likely here than in other states.
There will be, as I understand it, there's no scenario in which we would force involuntarily vaccinate someone.
Oh, no, yeah, I know that, I
Yeah.
just,
to make that clear.
yeah. When people already have sick kids and government officials roll up and start asking questions, people get pretty twitchy.
We've had weapons intimidation with building inspectors.
Yeah. Oh,
I'm sure environmental
That's
health
a-
has some stories too.
Yeah, I mean, so, I think from a board member, my biggest concern from a board member is in any kind of these scenarios where we have to go out and interface with the public when their children are sick, and they're talking about quarantine and their rights are being restricted or the right to travel, I'm highly concerned about the fact that Montana is much more armed than other states, and already has depression and mental health issues and suicide issues and all the other things we learn about in our lovely discussions. Those are all compounding factors that I would want to make sure that our interface with law enforcement, probably sheriff, thinking more county stuff or whatever from that aspect, is is probably more paid attention to than maybe would be like in downtown Seattle or whatever like that, just because I think the chances of encountering someone who's armed is much higher here than a lot of other situations.
So I just want to say that while we haven't actually had a situation where we've had to forcibly isolate or quarantine anyone, we do work with law enforcement in a lot of our different programs, and believe me, if we have an outbreak of measles, law enforcement will be calling me
Yes.
and asking me what they need to do to protect their own personnel and asking what we need.
Yeah.
So we definitely do have that good relationship with our law enforcement officers, that we know that they can call us, we can call them.
And Colleen?
I was just gonna say that I think the other, when I used to work in the infectious disease office, I mean, we have dealt with this on a much smaller scale when we've had pertussis outbreaks, or even if someone has Campylobacter or salmonella or something like that in a stool specimen and they're a food handler, and we've had to say, you cannot go back to work, depending on which disease it is, so don't quote me, but there are certain ones where you have to have 2 stool samples that are negative in order to return to work. And we've never, in the time that I have worked here, really had a problem with someone really being defiant, or, I mean, there are some people who are not super happy that they have to miss a couple days of work, but that is a much shorter time period that we're talking. And so when we're sending a healthcare worker home for 21 days, that is a huge impact. And I think we'll get around to this as Ellen finishes the scenario, but again, it's why we really advocate, and even with like legislation that has been happening and things like that, that people who are vaccinated and have the ability to be vaccinated, so should be. Because if you can be vaccinated and prevent something like this, you won't have to miss work for 21 days.
And to be honest, I'm inferring a likely scenario where it's going to be a low vaccinated area and the political leanings of a low vaccinated area. And, just, there's lots of information in my thought based on that we'd have to deal with, and that would be my bigger concern.
And I think, that we always, as the laws and stuff that Anna looked over say, you always employ the least restrictive thing first. So it would be always like, are you willing to do this? We really would love it if you would, and, kind of start at that. And I think we are all very nice ladies, and they get along with us. And Brad, he's a nice gentleman in ID, and people seem to be okay listening to what we guide them to do, but it could.
And almost everybody's watched
good to
Walking
have
Dead
it.
now, and the first thing they're gonna think of, you're gonna throw me in an internment camp and do all this kind of stuff and freak out. We can think modern, we can think modern film for a lot of assumptions people immediately make about quarantine or outbreaks or any of that kind of
Right.
stuff.
So what happens to somebody if they get measles and they're not attended to?
And we don't know about them because they didn't go in.
Yeah, I'm saying, but their own health, they die? What happens to
Oh,
someone?
I don't know what percentage would, some, yeah, I mean, there are.
They can get
Measles
encephalopathy.
measles
Yeah,
and
one in
stuff.
100,000.
There's a little cacophony of consequences here.
No, I mean, worldwide, there's still.
Yeah, there are a lot of deaths.
Thousands of
And
deaths.
I didn't bring my
measles.
article from.
Yeah.
What
last
age is the
month.
first MMR vaccine?
12.
12, so anyone under 12 months is at risk from anyone
Yeah,
infected then?
You can give it as early as 6, and we'll get into some of
Yeah,
that.
I just was thinking, yeah, when you're thinking about it, it's less maybe an adult or whatever, it's more the exposure of other people that's the bigger concern, because younger people are more likely to
Yeah.
get significantly ill.
They can-
And so under
they-
one, that's really sensitive group.
They
Well,
can
and a certain
remain ill for
percentage, a
life.
certain percentage of all people who contract measles will develop what's called measles encephalopathy. And that's usually, when you hear of a death from measles, that's what happens. And it's not just babies or people who are immune compromised. You can have a perfectly healthy child who is not completely protected by vaccination, that, you know, the parents are like, oh, it's measles, it'll run its course. But no, when measles encephalopathy happens, it happens very rapidly, and usually death follows very rapidly.
So if somebody already has that rash, they're full-blown measles, can anything be done? Besides just stabilizing the
No, there's
condition?
not a technical.
Palliative care, right? Yeah.
It's
You
a
just- you
virus,
just-
it's a virus.
So you're just hoping that they don't get
Right.
So
encephalopathy.
There's
one
no
out of every
specific-
40 children get pneumonia, 1 out of every 1,000 children will develop encephalitis, and 1 out of every 1,000 children will die. 1 or 2 will die from every 1,000.
And if the vaccines, that means every kid under one is in theory at risk if
Right.
there's an outbreak and any kind of exposure.
So
And,
what-
and any children who have a medical condition that keeps them from being able to be vaccinated with MMR, if they're immune compromised or
Pregnant.
something.
Pregnant women can't be vaccinated, it's a live vaccine.
It's live, I forgot.
It's attenuated live, but you can't give it to pregnant women. So, I mean, you know, there's, some people can really get into a corner.
Is it in short supply or is it readily available?
It's readily available, and we've been stocking up. Thank you, Colleen. So this is just a generic incident command chart. We're only filling 5 boxes right now, our incident commander, and that's how this works. You fill the box you need, and you grow as you need to. So I didn't do a chart last night because PowerPoint and I were, PowerPoint is some sort of artificial intelligence formatting schematic that was blew my head up last night. So I just put this in. We have our incident commander, we're gonna have a public information officer, liaison officer, chief of operations, and then we're actually gonna have a branch under operations, which is vaccine. And what is your goal of your vaccine branch? So your phone's ringing off the hook, because not everybody wants an MMR, but what is the goal of your vaccine branch, given that we have a case?
There was an active case, so I would be working under the guidance of Sarah as operations chief. So I think the first thing would be to make sure that we have an adequate MMR vaccine supply. So we'd order in some extra vaccine and make sure that we have the other clinical supplies that we would need. We're always going to be working with DPHHS also just on guidance for how to handle post-exposure vaccination in a group. So we'd be working very closely with infectious disease as well to figure out, while they're doing the list of contact investigation, that would be our first priority, is getting those people who were exposed vaccinated afterwards. Because like Ellen said, in 72 hours, within that, it can prevent them from developing measles. So even though we have all these phone calls and people are going to be wanting vaccinated, that's going to be our priority group. So we'll develop kind of a tier system of priorities. And I think going right after, as soon as the contacts are taken care of, would be the kiddos under 1, and really trying to do, we'd have to figure out the logistics of that, but how to reach that group. So any at-risk groups, we'd really put as a priority to receive the vaccine and get up to date first, as well as any like healthcare providers that will be taking care of those people.
May I ask a question? What is the expiration date on the vaccine?
They all have different expiration dates.
So it just depends, the lot numbers, we just, if we're getting close to one expiring, we send it back, order in new. So we always have plenty of new vaccine.
Okay, so somewhere in here, as soon as we learned a little bit more about this kid, we actually started building our incident command, because the next slide I'm going to show you is the result of a whole lot of people making a whole lot of phone calls and then making judgments on whether these people were susceptible when they were, first were they exposed, were they susceptible. So we're going to pretend all that happened, but this would, and then these are, we're going to read up some really quick incident goals, always in your first IAD, whatever it's called, I can't remember. And there's lots of objectives underneath them, and you're going to have a planning group that we haven't staffed yet, and they're going to start working on other work plans. But stopping the spread, that's it. I mean, that's what the law says, that's what we need to do. We need to move fast, that's a priority. We want to protect and as part of that, advise our healthcare institutions and schools, but primarily in this one, our healthcare institutions, because they will not be able to function, which we need in general, but we also need if we start getting an outbreak. They need to be available. And then our public communication, we're going to have some really interesting management issues with public and particularly social media communication. We'll talk more about it at the end, because everybody that was thinking of getting an MNR will now want one, and unfortunately they are no longer our first priority. It's the people we have to get first. Okay, so after all of this work, and I don't know how many phone calls, and I can tell you it's a lot, what we were able to confirm is that there are 2 other children at home, and they too are unvaccinated, and they go to 2 other schools. One's a high school, I didn't put this up here, we'll say one's a daycare. There were 15 waiting room patients, and again, to figure that out, somebody had to say, go to your appointment book, find out who was here, find out if mom and dad were both here, if other kids were also here, and then were you also here for 2 hours after this child, okay? So that has to happen, and then we'll check the immune or vaccine status on them. So all this is happening, and when we do the same thing with the healthcare workers in that particular office, and first you have to define office, it depends on the setup, on the layout. Is the receptionist really face-to-face? I mean, with this type of high contagion, those things matter. It's not something like if it's pertussis, you were the same class with the kid, but were you in this, what we call the 3-foot range? Oh, you weren't, we're not gonna deal with you. Okay, on measles, if you were in that airspace count. And then, of course, we have the cases elementary school. So we've got an elementary school case, and we've got 2 exposed susceptibles, let's say high school and preschool, and let's say folks vaccinated. That tends to be what you see. The folks got vaccinated, but now the current parents are not vaccinators, and that's kind of what we might typically see. Now, I've written these up here for each of these in terms of what police power or quarantine, isolation, exclusion type control measures. Again, there's other medical ones, but what police power, board required duties and authorities, how we would dispose or how we would exercise those control measures. And I've written it up here just for kind of teaching purposes. It wouldn't be the CEC. So, but let me just run through them. And also, chime in if I got one wrong. I tried this a couple days last night.
And it looks like for measles, you're required to employ minimal control measures, right, by rule?
At least minimal.
Oh, at least minimal,
Mhm.
okay.
Yeah,
I thought
but you offer all sorts of control measures, but the ones that you impose by police power, you start with the ones that are warranted and least invasive of their liberties.
And
just go from there.
And just to be really clear, what Ellen has up here is the minimal control measures
Yes.
Yeah.
for measles.
Okay.
I just noticed the last page of the powers one it said minimal,
Right.
so.
Yeah.
So the case itself is isolated because we have the case. And the case can be isolated at home if the child is well enough and if they don't use their home for a daycare. I mean, these are all the things you have to figure out. Other kids don't come over. And this one we know is an elementary school, but you have to know what else is going on in the home, and if you have the cooperation to do that. So that's classic isolation. The siblings, and they have to be isolated for 21 days from the time the rash appeared, okay?
No, 4 days.
4 days, excuse me, I'm sorry, I'm thinking of the healthcare worker. Okay. So they're gonna start feeling better, they're gonna wanna get up and around, but maybe not. It kind of depends how sick they are, if your contagion is walking or stays put. The siblings, because they're unvaccinated, their parents have a choice. They can get the post-exposure vaccine. We can't be as sure with them if, in fact, they got it within 72 hours because they live with the child. So while this looks nice and clear, you get the vaccine, we would have to sit and really talk and probably consult our infectious disease advisor, Dr. David Christensen, and say, I don't think, they may be past their 72-day window.
So that in this particular scenario, because they didn't take the child in until the child developed a rash, siblings would not be able to get vaccinated prophylactically, post-exposure prophylactically, because they've already, the original case has already been contagious for 4 days.
So you'd have to run the entire incubation period out before you could allow
You have
them
to go
be around other
backwards,
people.
when
Okay,
and they
yep.
didn't know they were sick. Now, if for some reason, it turned out differently with measles usually. But we're still gonna offer the vaccination, because we want these kids vaccinated, go around. And then they are excluded for the incubation period. The healthcare workers, again, we get into some, and these have been made more stringent with the reemergence of measles. So these are much more stringent than they were last time I dealt with measles. You used to be able to give a healthcare worker post-exposure vaccine and they could go back to work. No longer. The guidance is very stringent, and you are to offer it, but even if they accept it, they can't go back to work for 21 days because it's not 100% effective, and they'd only have one dose, which is about 92% effective. The waiting room folks, if the child that was in the waiting room is at least 6 months old, we can vaccinate with post-exposure. The pregnant women can't. If it's an infant, can't. But then if they do accept that vaccination for post-exposure, then they can go back about their business. Okay. The kids in the cases school, in the ill child school, those children, what's really difficult with school is who are those children? So if you're in an elementary school and they didn't have gym that day and they weren't in the cafeteria, or they came in for an hour or what, you have to go back.
They all have recess together.
You have to figure all that out. As you get up into the ages where they're moving around the whole school or the whole campus, you've got exposure everywhere. So those are the things that you work through with the school nurse, the school officials, and try to understand all these things. But that school is now highly affected. Highly effective, and so they're going to, typically what Missoula County Public Schools will do when they work with us is they'll say, you issue the recommendations. When you issue them, we're going to put them in place. And so this is a point where you've got an outbreak, and the school, even the children that didn't have, that were legally exempted. So they're legally exempted because they had a medical exemption. Their doctor said, you just can't get this MMR, or they chose the religious exemption. In an outbreak, the health officer's orders still are that for outbreak control, that's fine. You can stick with your exemption. You can choose not to take the post-exposure prophylaxis. But if you choose that, you are excluded for 21 days from school. And then we're required to check on them to make sure they stay out.
And that's for all children who have not received at least 2 MMRs. If they've had one and didn't get the second, they still fall into that category.
So if the parents gave them one but decided they don't want to do it the second one, then.
So you get all these little details you have to.
Yeah, if they got the second one, they can go back to school. because they're different than a healthcare worker, but if they didn't have any.
So does someone have to go, one of you guys have to go and review vaccine records then?
With the
We
school,
work
well,
with
what we
school.
try to
We
do
work
is
with
get the
the-
school to do it and then work with us, because we're kind of tapped.
Yeah.
Yeah.
Kind of.
Especially if there's multiple schools being hit at
Yeah.
the same time or something, right? Yeah.
And then the kids in the sibling school, so we've got a preschooler, unvaccinated, definitely exposed. We've got a high schooler, definitely exposed. What we tend to get is a whole bunch of calls from all the schools, particularly his son's in my chemistry class or his kid's in my daycare. We want to educate, we want to ask them to review vaccine records, but what we don't want is them all rushing to be dealt with as if they were exposed. If you're exposed to a contact, it's not the same as being exposed to a case. So being exposed to a contact.
Yeah, because there's a delta for incubation and when you're infectious, so.
Right. And the one thing that we would do, because Ellen's bringing it up, is that we do actually work with OEM, with the county, and we can stand up a call center pretty quickly. We did it with H1N1.
It's all ready right now.
Yeah, we've got everything in place so that if we actually need to call in other staff that don't normally work for the health department and have a nurse over there with a script to be able to figure out how to field all of these calls, we're set up to do that.
It's just
So-
that fast and focus is the hard part, because everyone's calling, they want vaccine, they know the family. I know the family, what do I need to do? You know, those kinds of things, so the public messaging and the social media. Now, this looks like it's almost cut and dry, but it isn't, because remember the beginning of the scenario? The child was sent home with a suspect diagnosis of measles. Thank you, doctor. Drew a lab. We don't have a lab test. So if the family chooses to not cooperate, either with the case, usually the case is gonna get sick enough to stay home, but with the other children, then we've got an issue, because we don't have lab confirmed yet. And so that's when we start weighing out, how far do we go? You know, are we gonna really look at true quarantine here? Are we gonna look at exemption? What are we gonna do to get it? Generally, depending on the day of the week that the lab was sent in, we're all, including the family, only gonna live in that gray zone for a maximum of 3 days if it's a weekend. Usually more like a 24-hour to 48-hour period to say, look, we need you to stay put until we know.
And I've actually talked to the state and the state lab, and even if we were to have a lab that came in on the weekend, if we get a hold of them and say, hey, we're highly suspicious that this kid has measles, I'm gonna drive the specimen to you, and can someone meet me at the lab, they can get us results on the weekend. So that's new since our last big
That is good.
outbreaks.
Yeah.
So,
Where it gets really difficult is when you start putting, and then the board needs to understand what's going on, or question what's going on, or help decide what's going on, is how far, let's say you do an exclusion policy for a whole school because of the information you have at the time, and the whole school doesn't want to do that, or many of the parents don't want to do that, or they can't do that. That's when you've really got to sit there and say, what must we do, what can we do, and then logistically, how can we make it happen? That's where it's very tricky, and people start to push back, particularly if you're looking at 21 days. Anyone would push back on 21 days, so how do we do that? So it's not at all cut and dry. You've already heard all the reasons this isn't cut and dry, but this is sort of like to apply isolation versus exemption versus post-exposure treatment.
Well, I mean, if those kids aren't vaccinated, looking at your 9 out of 10 develop it, most likely those siblings are gonna develop the case, just
Oh, yeah.
statistically.
Yeah, but without a lab case and a person who, whatever reason, doesn't.
Looking at this, you can see, well, what other places would they have gone besides?
Oh, this doesn't even
This is-
count,
this
the
is-
birthday
do that.
parties and
State track
The
meet.
mall.
No, and the traveling team.
going to
This-
Costco.
this-
Yeah.
Like this scenario, you
And
can
have
see with
samples
enough
at every
people working
place.
the phone, so you get a handle on it.
Yeah.
But it's quite easy to imagine a
Oh, it was
situation
awful.
where you can't get a handle.
Our last big one in Missoula was the first year of the International Choral Festival, and it came with a group of children from another country, and those children were quarantined. They were unvaccinated, and they were quarantined and actually sang from another room over a speaker or something. It was not a
The
popular.
show must go on.
It was not a popular situation.
Well, to give you a real world example, when we were having a lot of cases of pertussis several years ago, we kind of estimated how many contacts we would get from one case of pertussis in a high school student. And we were between 400 and 600 contacts to one case of pertussis, which is, you have to be within that 3-foot spitting distance to be considered a contact.
It's gonna be
Incredible.
Pauline, and then I want to turn to our PIO.
Oh, no, I didn't have anything to say. I was just doing this, just agreeing.
I'm just doing the math of the vaccination rates at 93% and the exposure rates in this town for that. And I'm like, someone goes to the mall or someone goes to an event, this is gonna get really complicated
No,
really quick.
we're definitely sitting at best or below optimal.
Yeah.
And then that changes as you go from daycare to daycare, school to school, or church group to church group. You know, that's what you start to, and that's the population that you really have to look at. If that vaccination rate is below 93%, and some will be, it's gonna go.
Have you all, has anybody ever run into a case of measles where someone actually did go through both rounds of vaccinations? Where they were in the 7%?
No,
Not the
the
93?
second dose will give you 97%
Okay, so,
protection, so.
but one, they got the first one and they just haven't got the second one.
We haven't, but we haven't seen measles for so long.
No, there was a case in Clark County, Washington outbreak where it was a child who had received one MMR and still contracted the measles.
Yeah. So, other things that we haven't touched on, in particular, a little briefing, or what is the public information officer paying attention to in this early stage? And don't forget that the school will send out that text. There has been a child diagnosed with measles in your school, and
Yeah, so I'd be working on public messaging and working with the incident commander and liaison to make sure that we were coordinated with the schools and other agencies, trying to rein that in and monitoring social media, and then fielding questions or fielding the media requests. I probably wouldn't be the spokesperson, but I would be trying to coordinate a lot of the behind-the-scenes messaging
And in this situation, probably Ellen or I most likely would be the person that would be, people that would be doing the interviews. We usually just pitch it, like whoever's got the most availability at the moment that a telephone call comes in.
or we get Dr. Christensen, or
Yeah.
we get Dr. Stenker when they think people really need to hear from a physician.
Yeah.
Usually that's helpful. Anything for your team to add, or Sarah's?
I think Colleen covered pretty much ops. So it's just making sure that we have the supplies, the vaccine, and the staff. And then when things start getting bigger, then it goes into the planning section. And so using our other visiting nursing staff that they don't usually give immunizations, so we do just-in-time training with them to make sure they remember how to give a sub-Q shot and screen for measles, but we have other nursing staff that we could pull from home visiting to help with this, and look at scheduling off-site clinics to be more accessible to people if we need them to be for certain populations. So it just would continue to grow that way.
Do you have anything, like, team member? Are there other observations, questions, or?
Have they gotten the outbreak in Washington/Oregon under control, or is it still spreading, I
You
guess?
can't, so.
I mean, I guess it's not been 21
Until-
days of no
until
cases.
two incubation periods.
2 incubation
Past the
periods.
last diagnosed
So
case.
42 days then, yeah.
Yeah.
That's the last case.
And if you don't think your surveillance system is good, so like if you're dealing with Ebola, for example, and you've got all those challenges in a different resourced country, then you might say it's 3 incubation periods. But for here, in the school, we would say the outbreak was over after 2 incubation periods of cases.
I did see an article, I told Ellen, that a judge, so somebody must have not wanted to go with the isolation measures, and a judge imposed that there were 40 children that had to stay out of school for the 21 days.
So they're still in it.
They took it to court, like, very quickly, I guess.
Yeah, I think that's what we'd want to do, is we'd immediately want to get a judge, like backing up whatever we wanted to actually do as quick as possible.
Well, and when we were dealing with a lot of pertussis outbreaks, we did get some pushback from parents about not wanting to prophylax, but also not wanting to have to be monitored for 21 days. And it never became a legal issue, but it definitely could have, and we did see it in some of our neighboring counties where they did shut down the school, and they did force a certain number of children not to come to school for 21 days while they were being monitored, and it can get legally sticky really quickly.
Especially if Gallatin County just went through their second round of mumps and had exclusions in the schools and got lots of pushback, and that's where the board, in addition to this team, the board really needs to be involved, and we have to understand that we're all on the same page.
Yeah.
And that we aren't. Anything else for now? Thank you. I hope it helps.
Josh is like, what did I sign up for? I can tell right now. He's like, wait, you mean I might have to make someone stay in their house? I see that right now. I can tell the look on your face when you start looking at it.
We'd already do a case by case for TV.
Not good.
I mean, they're homeless, we get them a motel room and
Good.
give them stuff to read.
Yeah, be assured that we have experienced staff who've
Of
dealt
course.
with big outbreaks, and we can handle it.
I
It's
wasn't
just, it's
concerned
gonna
about
get very
that.
complicated.
Thank you for the extra time to take this opportunity. Thank you, incident command team.
Sure. I guess Josh steps away. Ellen, do you want to give us a legislative update?
Yeah, well, we had some with excellent testimony prepared by Sarah Heineman and. Yeah, I was just gonna praise you, you can go, you can stay, bask.
You did a great job.
Yeah, Senate, but did you watch it?
No, she told me all.
Oh, my gosh.
Oh, yeah.
This is wrong.
This was, this is the pharmacist
Oh, giving
wishing to
vaccine.
give vaccines without any medical oversight and so on and so forth. So that bill is being amended. We had executive action, didn't happen last night. That would at least put them under medical oversight and use of the state registry. It doesn't really help with the fragmentation that occurs when you just go to any pharmacy away aside from your well child check or your physician, and it doesn't help with that. But Sarah and Colleen were the lead testifiers, and the data they put together to debunk the proponents' selling point, and it was really like a retailer's selling point. Access, access, access. She developed a map of Montana over the weekend, made a zillion phone calls to show that the pharmacy access they're talking about doesn't exist to start with. And so this doesn't add to access, and in fact, the public health access does exist in every county. And then Colleen followed up on the complicating factors and how many immunizations and why anyone giving immunizations should be under medical oversight. And so those two pieces are being looked at.
Good.
And we hope that will be amended. House Bill 481 is the Cigar Club bill. And it is in a committee that is, I would say, it's Senate Business and Labor, so that's a committee that's more friendly to those interests than to public health interests, and we've been working it in everything that we have. They still haven't taken executive action. We are basically hoping that we could get it killed on a tie. It's a 10-member committee. That's the best we'll be able to do.
What do you speak?
The Cigar Club bill. I think you got commented about it. We're also.
I wasn't aware that it had such a slim
So if
chance.
we have to work it on the floor.
There's a lot of money
yeah.
behind it.
Yeah, we're also concerned
So-
because there's, you really have to watch that testimony.
Yeah.
Yeah, it's quite entertaining.
Very entertaining.
I can't, I get so frustrated.
You really,
It's frustrating.
I've seen a lot of things,
Yes.
so this was a good one.
I know some of the people.
But we're
Yes.
also concerned, we're, I'd say, almost equally concerned, if not more, that an amendment that might look at separate ventilation might be viewed as a fix, but in fact, separate ventilation still has to be in the building that you have separation. And our problem over here is we've got a leaky building, and you also can't fully separately ventilate a Class A carcinogen out because there is no safe level of exposure.
I
So,
love that term, no safe level of exposure.
yeah, so then there's a bill that's similar, but it's actually a revenue bill, which is why it's being introduced so late, because it hasn't had to pass
I just
chambers
learned
yet.
that, yeah, the revenue bills can
House
be
Bill
introduced way later.
644, and that's for cigar clubs that can also serve alcohol, so we're working on that
So
one.
it's, oh, bars.
That-
It's a bar. It's
Yeah.
become a bar.
It's a smoking
become
bar.
It's become a.
With a $5
it's become a
membership?
Which is
20th
what I
century bar.
thought we got rid of 20 years ago. So,
Oh,
1998 bar.
a business idea.
there's a
I'm
lot
sorry,
of-
I don't.
I'm giving you the bad ones. We got three raw milk bills killed, one killed itself, actually.
Are any raw milk gonna go through?
No,
Good.
no.
Did it kill itself by drinking raw
We
milk?
won't talk about raw milk for 2 more years.
There's a lot of good bills, particularly by some Missoula legislators. Diane Sands and Kimberly Dudick have a bill for a safe harbor for mothers with addiction
Great.
problems and babies that we supported. And the tanning bill, you know, the kids.
Tanning bill?
The kids shouldn't be allowed under age 18 to just go to tanning booths, and that's its 4th time up. The seatbelt bill is back for its 4th time to try to get it passed.
We're still having fights about seatbelts.
We are still having, and they're very symbolic. These things
These
are
are
all,
personal
the
liberties.
cigar clubs, seatbelts, the immunizations, all of those are really.
Did the public health bill that we were
political.
observing, where'd that one end up at?
Which one?
Wasn't there a bill that was coming out of like some?
Oh, yeah.
Gallatin
Yes,
County
I'm sorry,
bill?
that is Senate Bill 179, and that actually limits health boards' authorities to do anything different than the Montana Clean Door Air Act without
remember that
getting the
one.
approval of the city and the county. And that hasn't been acted on again, and
Okay.
they're just working and working and working to try to kill those two.
That was the one I was thinking about. I was thinking, there was one that restricts health board stuff.
I would really got the authority.
Well, at least it's narrow. When it was first talked about,
It's more about smoking.
it would take
would
all
limit it
authority.
or
Yeah,
whatever.
you would have had to
Say-
change all these laws. Yeah,
It wouldn't just be by precedent.
right. So anyhow, that's what's going on, but a lot of work, a good way. Thanks, Sarah.
Thank you.
You should tune in and watch Sarah and Colleen on
I'll look at it.
It was just
They,
phenomenal.
oh my God, they did it over the weekend. Colleen goes, here's the guidance for childhood immunizations, and she goes like this, and it just drops. It was
Perfect.
amazing.
Good.
Thank you.
We'll circle back for the journal report.
All right, sure. So the journal article, mild liberties with this, the journal article I'm looking at is more of a white paper. This just came out a couple days ago.
Cool.
I was going to take the easy way out and talk about something I felt really fluent in because I've been busy with this new gig. But I heard about this and it just came out a couple days ago and really piqued my interest. So pulling a chapter out of the World Happiness Report for 2019.
Awesome.
It just
I love
came
it.
out. This is for the United Nations put this out. A bunch of scientists.
Denmark, blah, blah, blah. I'm joking.
They got it going on.
Aren't they the
I guess
happiest
we're done
nation in the
now.
world? Yeah, just give me a minute.
So of this 50 pages, most of it is a discussion that would be called in a typical journal article methods. It's a description of how the numbers were collected and crunched. I'm not going to focus on that, though I understand there's I'm probably the only non-researcher by trade here, so I guess we could have done that. But given that it's me doing this, I'm going to talk more about the conclusions of this chapter. And if you really want to dig in, have at it. You can beat on where they got the numbers from and how they did it. Things that I thought methods-wise were kind of interesting. What did they use to measure happiness? Well, there were three things. The first one was called the Cantrell ladder, which you health folks may know about. This is a 0 to 10 self-reported description on how's your life going. The next two are positive affect and negative affect, where the person self-reporting describes the positive and negative emotions they're having. One thing I liked about this description was that the two happen simultaneously, because most of us are never all one way or all the other way. In fact, there's some interesting examples where you can mix joy and envy simultaneously, where I could see that Anna's going to San Francisco for this awesome conference, and I'm really psyched for her, and I wish I was going to
It
San
was
Francisco.
actually Costa Rica.
I love Costa Rica. I had that simultaneously, which I thought was a very realistic description. So these three things are added up to determine a person's happiness. So some of the, and before I jump to conclusion, some of the interesting things that came out here are due to the fact that this study has been going on for quite a while. So this latest one that came out 2 days ago looks at a compilation of data from 2011 to 2018. So there's really some nice trends that are described. And some of the conclusions are about trends, and some of the conclusions are about right now. So in the trends category, smaller countries have been creating, have had greater happiness growth than larger countries.
Dang it.
So still like Bhutan. Bhutan wasn't that high up. But, this is
Really? They weren't that
and what I'm
high?
usually
They
about.
dropped fast.
What I'm speaking about here now is not where they are in their ranking, but their growth and happiness.
Yeah.
So even like the biggest one I think was Benin, which is way low, but they had experienced a high degree of growth. So generally speaking, smaller countries, a higher degree of happiness growth than larger countries. Globally, there's been an increase in the negative affect. So globally, more people are experiencing more stress and anxiety than they were 2011 on up. And we can come up, we probably have all kinds of good
All
ideas on
sorts of
why
reasons.
that
I was like, we should do a social media / whatever
Yeah.
cross-reference of that and see the impact.
Within the Americas, increase in positive affect is generally falling. And what they were calling the Americas, interesting, was North America, Australia, and New Zealand. So
Oh.
since,
That's
that's how they lumped it together, Americas and then A/NZ. So, and since the recovery.
It must be a
from the Great
cultural
Recession-
alignment, yeah.
So since the Great Recession, the degree to which we are getting happier is going down. A degree to which we're experiencing positive affect, not general happiness, but positive affect. Globally, happiness inequity has been increasing, driven by increasing happiness inequity within countries, not between countries. It's kind of an interesting one to, yeah. And there, obviously, we could jump right to economics, but I'm not 100% sure that that's the case. So, next one is a little bit about economics. The effects of happiness inequity are often larger and more systematic than those of income inequity. And the effects here being things like participation in civic and social affairs and general health and well-being are not, they don't exactly correlate to economics, and in fact appear to be more powerful than economics in the determiner of a person's participation in social and civic affairs or general health. Happier people are going to be healthier necessarily than wealthier people. Yeah, happier.
Correlation is not causation.
Right.
So I thought this was kind of an interesting piece, this was a bit on methods, but when looking at the happiness scores, like Denmark scored really well, the scores were broken down into what explains that score. So the score gets explained along 6 variables. So if a country got a score of 99, out of that 99, some of it was related to GDP, so I'm going to rattle these things off. So these are the things that explain happiness. GDP per capita, social support, a safety net, healthy life expectancy, which I thought was really a good thing, not just life expectancy, but
Healthy life expectancy.
Freedom, generosity, absence of corruption in local government.
We're screwed.
Local. Oh my gosh, I'm sorry.
I gave you the $20 at lunch, you weren't supposed to say that. That's not enough. Yeah, it's not enough. So really interesting, these are the things that are used to explain happiness in a country. And now just hit the rankings, which of course, Denmark, right? It was Finland, Denmark, Norway, and Iceland. So
Also super homogenous societies, by the way.
Yeah,
So.
Yeah, the cold and
Wasn't
dark.
done, and I'm
Getting a little more.
Not so much
diverse.
anymore.
So those were the
My
top
last
four,
visit
and then,
still.
and they're so close in rankings that it doesn't really matter. The difference between 1, 2, 3, and 4, they could just be basically be the same. We're at 19. Put it in perspective. Here's an interesting quote, and I chose this chapter out here because I'm working in local government, and this chapter was about government. Here's a quote from this report: "Government institutions and policies set the stage on which lives are lived, and are among the stage on which lives are lived are among the primary factors influencing how highly people rate the quality of their lives."
Wow.
Really interesting. Again,
It does
those-
explain a lot of things.
Those Danish countries, or not Danish, those Scandinavian
Scandinavian.
countries. And as you pointed out, super homogenous. I was in Denmark last year, and everybody looks the same. It's definitely really homogenous. And if, depending on how much you care about these things, they haven't done very well with.
There's a great article on
immigration
Medium
refugees.
about how Danes won't tell the truth in these surveys too. Because they want to keep their score high, so there's actually a really cool article on it I can send around too. They're like, they're always like, are they just lying for a national reason now or whatever?
It's like USA.
I thought it was
So,
funny.
and then because I was interested in this, I went outside of this study and just looked up, like, why are these Scandinavian countries always so happy? And you probably all know the answers already, but I thought they'd be worth reciting anyway. In terms of work-life balance, people who live in these countries believe that they're much heavily more weighted to life than to work. Last year, I was in Denmark, and my wife and I went to visit our college-age daughter who was doing a study abroad there, and she's going to school at a Danish college for a semester, and one of her professors said, "So you American kids in the room, don't email me on the weekend. I don't answer email on the weekend."
Really? That was just part of their,
Yeah, where I'm like exercising at 6:30 in the morning and answering email while I'm flailing my limbs. Always available. You can't do it on a Saturday. You don't expect that from your professors in Denmark on a Saturday or
oh,
Sunday.
I love it.
Huge amount of time for maternal, paternal leave or other family leave considerations in the 400 plus days. So nothing like we would do. 3-week vacations are the norm. It goes on if you're into that stuff.
Stores aren't open on Sunday. You get your shopping done by noon
Absolutely.
on
I saw this
Saturday.
I saw stores open it, not catering to my desire for convenience when I was in Copenhagen.
Could get a shot
The
at
second
any
one,
time, any place.
people are outside and there's
Outside.
correlation. So I saw this in Denmark in November where it's cool out, not super cold, but cool out. People sitting outside in cafes with chairs set up, tables set up outside, blankets and a little heater. And they're hanging out outside. We would never do that.
Tell me they weren't smoking.
No, I
I love that picture.
And outdoor recreation is this huge economic driver here. A different type of outdoor recreation, not the extreme badassery outdoor recreation, but people just walking, sitting by water, just choosing to hang out outside rather than hang out inside. The fourth one, a very high degree of public trust and an emphasis on a feeling of community. So people living in houses more closely together, talking with one another on public transport.
It's making me anxious, thinking
In-
about that.
From a public health perspective, yeah. Enforced coffee breaks.
Enforced?
Yeah, like, so enforced, but you don't have to drink coffee, but
You
you're
have to take
sitting
a
at your
break.
desk and everyone else has gotten up, they're gonna go, Debbie, you really should take a break. Like, you'd be, come on, go do, even if you just wanna walk, go, go, go. Often these coffee breaks encourage conversation. So it seems like a higher degree of importance placed on informal contact with, again, public health issues, but notwithstanding.
This is fun.
And then the last little bit on taxes, which is everyone's first, and I have to, given we have a few minutes, I'll relay my own personal anecdote. So it was in the fall, I was walking down the street in Copenhagen with one earbud, listening to NPR, because I want to know what's going on in the United States. And the debate among pundits were around the Trump era tax cuts. And I was hearing in one ear, if we do these tax cuts and remove people's public good burden, they'll have more money to spend on their businesses, they'll invest in businesses, wealth will accrue, the rising tide will lift all boats. And I'm not here to argue for or against that. That's just the voice I heard literally in one ear. Walking down the street in Copenhagen, bemoaning how little money I have. Not because I am an upper middle class person, I legitimately don't have, I'm not poor. But it was $6 for a cup of green tea in Copenhagen. So I'm feeling like, God, I don't know, geez, a muffin for $6 and a cup of green tea for $6. Jeez, I can't keep up in this economy. That was the voice in my head. I can't keep up in this economy. And the other voice in my ear saying, if you tax people heavily, their economies will fall. Can you see the internal conflict that might be going on?
Yeah.
And I'm not saying that the Republicans were wrong or anyone was wrong. I'm just hearing one voice saying, heavy taxes will crush an economy. And I'm walking through an economy with heavy taxes that is outperforming ours. And it was just a lot to, and all this open to debate, okay? I'm just telling you what I was feeling in that moment. We can have the debate. I'm just telling you by anecdote. So marginal tax rate of around 50% compared to 27%.
But they don't have to pay for
Absolutely.
education.
They don't lose their house if they have a health problem.
And one,
They don't have
yeah.
to pay for health
and that,
insurance.
and one of those
We have a
reasons,
lot of weapons to maintain, so.
and one of those reasons why they're happy on this safety net side, people do not have anxiety that the rug will be pulled out from under. They will end up homeless, or their house will be closed on. It doesn't. And I'm not saying it's a paradise. It was just really interesting. And when hanging out with the host family that hosted my daughter, wonderful people, live in a nice, well-to-do suburb of Copenhagen, definitely people who are not on the bottom end of things, they openly complained about how much taxes they paid, and they complained about the people in Christianshavn, this district in Copenhagen that's famous for brash drug use and people laying around making art in the middle of the day, not working, not contributing.
Making art?
Yeah, we went and visited. There's people doing all kinds of art right there. Tuesday at 10 in the morning, they're doing art instead of working. So, the father in this household was really complaining, like, this bugged the hell out of him. It bothers him.
That sounds
that
like
he
the
pays.
Scandinavians I know.
Yeah, he pays, I pay all this,
Free loaders.
he's like, I pay all this in taxes, and then these people in Christianshavn that are just smoking weed and drawing pictures. This is totally not fair. And what I thought, again, open to debate here, this is just what I was thinking, was that there's a cost to all systems. And the cost to our system is that there are homeless people who we have to figure out how to keep from freezing to death or annoy you when you're walking down the street. The cost to this system is there are people making art in the middle of the day. And we just sort of have to kind of add up which cost do you want to pay?
James, 2 minutes.
All right. Well, and then in our dinner conversation.
Reclaiming my time.
In the dinner conversation with the Danish folks who treated my daughter so well, and I owe them a lot, very kind and smart people, said that they were aghast when my daughter goes to one of these fancy pants Northeastern liberal art elite colleges where wealthy people take advantage of their privilege. Guilty, right? And when they found out how much we spend to send our daughter to this college, their jaws dropped. And then I could see them thinking, not just out of surprise, but they're thinking, y'all are ridiculous. Like, why would you do this? They don't pay any money to send their children to college.
That's correct.
They don't pay anything for healthcare. And their beautiful suburban house was quite close to the next suburban house.
Technically.
They ride the train.
I mean,
They do.
You're
do
paying
pay.
for
They
networking
pay.
and access for
Absolutely.
your daughter, by the way. It's the relationship she builds there and the alumni network that'll get her employed later. I mean, that's what you're
Dude, I
actually paying
get
for.
that. I get that. And I'm writing those checks.
Yeah.
I'm not saying it's wrong. You
Yeah.
know, I'm psyched that she had the wherewithal to get in and we had the wherewithal to pay. Just saying the people on the other end were aghast at it. And we could say, well, they do pay. They pay in their 50% marginal
Yeah,
tax rate.
right.
It's just an interesting
But they pay
conversation.
less than we do when you look at all the things that we pay, so, yeah.
And I personally don't believe that our system, it's too big to change, so I'm not gonna scream that it has to be changed.
Never say never.
Yeah. I've been in a lot of countries undergoing disruption. It's usually bad in general. You want slow change, not rapid
So,
change.
I'm supposed
Yes,
to give
it
my
is
article
very-
to somebody?
Very
Oh, that's cool.
interesting, yeah, to Julie.
Yeah,
Yeah.
and she'll put the citation in.
Thanks for giving me the
minutes.
opportunity to
Yeah.
read up on something.
grab
Yeah.
it.
When I saw the
think
happiness
I'll-
report, it cracked me up, because I just read the Medium article like a month ago
Right.
about how the Danes won't answer correctly. They just want the score to be high, so I thought that was pretty funny.
Well, I think this year they were number 2 behind
Yeah.
Norway.
So they're slipping.
They're slipping.
Norway's interesting because they have the oil money. They're able to really adjust their social system and do a lot
Sure.
more. And then they don't have the immigration issues that Sweden has. So it's really interesting to see the juxtaposition between Norway and Sweden, where Sweden has these immigration issues and Norway doesn't, but the societies are very similar. And so the impact of what's occurring in Sweden versus what's going on in Norway and the happiness ranges has been very interesting to follow.
Cool little TV thing, if you're interested, you've seen Occupied.
Uh-huh.
That was like, what if their oil money goes away?
Yeah, it's not good for them.
No.
Thank you, that was
Yeah.
fun.
Ellen, we're up to director's report.
I plan to take some time off next week, but I'll be pretty much in town, but I will, of course, appoint someone in charge. And I'm waiting any day for my historiography on the pandemic, 1918 flu pandemic in Missoula.
Wow.
I had the galleys 3 weeks ago, so it should be coming out at any time, and that's in the Montana Magazine of Western History. So if you're interested, I'll send you a link.
Cool.
That sounds
Yeah,
Very cool.
I put my dusty old archive back under my desk, and because it'd been there for so many years, and I missed it while I was working on the article, and I've been keeping my feet on it for 10 years, so it was really good to finally see it in the galleys, at least.
That's great.
Yeah, it's fun.
And accreditation, we're uploading.
We're uploading we're submitting the application, and then we'll get the whenever to start the next worrying part.
Okay. Maternal Child Health Advisory Council update?
So lots of what I was going to talk about has already been talked about,
Oh.
which is awesome. We kind of started the meeting out talking about a dental bill that would allow hygienists to apply silver diamine chloride to teeth, and that passed. So that was a good thing. That allows hygienists who go to nursing homes and to daycares and things like that to be able to apply that, which immediately stops cavities.
Wow.
So it was kind of a big deal that they let that.
That is a big deal.
So that was kind of good. And then the next thing that was raised was a concern that one of the council members had about social media sites that were promoting the giving away or selling of breast milk, and the health issues that might be associated with that, not knowing the person that you're getting the breast milk from.
It's a whole thing.
It is a whole thing.
And people are like making cheese from it and all sorts of stuff.
This is happening.
In Missoula, though.
This is happening.
Yeah, it's a huge big thing. And so, there's lots of issues that come up with not knowing what
You just don't even
medications
want to
you
know.
might be on, and you're giving this to and how to keep it and store it and blah, blah, blah. So we talked about what we should do about it, and we ended up deciding that we would share information and concern with the Breastfeeding Coalition and encourage them to tackle it as a coalition. So it seemed appropriate place to go. And then we had kind of updates from the different departments, since Sarah talked to us about the grant for the foster care issue. So we've already had that little piece. And then WIC gave an update and discussed House Bill 290, which would require a mother to apply for child support and receive it before they would be eligible to get apply for SNAP benefits. And so that is a huge concern and has not been settled yet. But,
No, it hasn't.
Oh, no, I don't think so.
I don't think so.
Yeah. So that is on the horizon, which would, of course, endanger tons of people from getting SNAP benefits. So that was that. And then the immunizations talked about prepping for measles, and we had a whole big little thing going on about that. And then the Nurse Family Partnership reported. And I'm going to just kind of pass some of this stuff around. They've put together a fact sheet for the Nurse Family Partnership, and a little handout that they've got for their clients. the program's 85% full, which is pretty awesome. There is an article in Women's Day on home visiting and the program for the Nurse Family Partnership as well, which is why I have that. I don't usually carry around a Women's Day magazine, but that's also there and kind of promoting it on a national level, which I think is really good. The partnership requires in their rules that there be a board meeting or an advisory council meeting in our case that interacts with the partnership 3 times a year. And so we've decided as a council to set aside half of the meeting in January, May, and September for that purpose to discuss board issues or advisory issues. And the first thing that we're going to do is help set some goals for the program. So this is that.
Thank you. Awesome. Thank you. I don't see any public comments on items not on the agenda. Seeing none. Any other board or staff comments on items not on the agenda?
I have 2 comments. One is about outbreak stuff. There's some really cool stuff that the World Health Organization is doing with geofencing on phones, where if you know someone was there, you can geofence an area and automatically pull up all the information that someone was in the location for public health tracing. Now, I know a lot of people don't like that, but it's pretty fascinating. From there, and then the other one I was thinking is, I'd love to talk to the public health department about doing a weekly podcast on public health.
Really?
And just setting up something in public. I've been involved in a couple now, and they actually get a lot of attention real quick. And so you can pretty much do it for free through Spreaker and get it set up, and it's really easy to set up all the podcasting stuff. So you can just have people or guests come in, talk about current issues, do something 30 minutes, it automatically publishes. Once you get 5 episodes, it automatically pushes out to iHeartRadio and iTunes. And so it could be something that could really quickly. Yeah, it'd be fun. I mean, I might have all the podcasting studio equipment now too. So I might just be able to roll in, set it up in someone's office, do it, and roll back out. So.
Cool.
But it's something I thought could get public health
Yeah, I
messaging
think
out
a lot of
really quick.
people would like that.
Yeah.
I got scared at the weekly part just because weeks go so fast, I can't even catch them, but the overall suggestion
I'm
is
on
interesting.
one twice a week, and it becomes a habit eventually. So.
Really? Wow.
So you just parcel it out to the
Yeah.
departments and
Sure, easier than writing it, isn't it? Just
All things hemp.
interesting.
There's a bunch of farmers and stuff that we get together.
So
I'll bring it
We
up
had
to
Court
the
Jensen from the
Janet.
state on it as our
Public comment
first
for Board of
person.
Health or air?
So.
Air, okay.
You know Quinn?
Either one.
He was our first hemp farmer.
Okay, we'll do air. Is that okay? Okay. So we will adjourn as Board of Health and reconvene as the Air Pollution Control Board. And Jan, are you gonna do or Sarah you're gonna do the?
Sarah's here to do that, but
Oh,
I want
I didn't see you.
to speak as public.
Okay, perfect. So, yep.
All right, so the Air Quality Advisory Council met on March 5th, and our meeting was basically 3 presentations. And in the first one, Dave Atkins gave an update on what happened at the Woodstock Design Challenge this year, where there's, I think it's the 3rd one that's happened now, where a challenge is put out to folks to create the cleanest wood stove possible. And this one had an added component of make one that can also generate electricity. And so there's some kind of neat things that are coming out that can do a pretty good job with having really controlled emissions, getting the user out of the equation. A lot of things use sensors or other controls to basically take care of what happens inside a burn chamber so people don't get fiddle with it. Interestingly though, and Dave had the caveat of these are prototypes, they were monitoring the indoor and outdoor air quality in the tent where this was happening, and the indoor air quality is apparently quite horrible. Because these are still wood stoves, and when you open them up, smoke still comes out to load them.
And that's in a tent?
Yeah.
Wow.
So, they're still wood stoves, so indoor air quality is, I think, always going to be an issue until they make something even more amazing. So that was great. Then we had Chris Miglaccio from the university come and talk to us about his ongoing health study with Seeley Lake residents who are exposed to smoke from the Rice Ridge fire. And what they're seeing from that is reduced lung function, really basically across participants. And the lung function has continued and sometimes a little worse a year out from the fires. He has the caveats that these are just 2 data points. And so he's going to try to keep going back and also expand the study to include other communities that are exposed to wildfire smoke. We're trying to get some longitudinal studies going where they have communities where they can get some baseline health data and then some after smoke exposure data. 'Cause we don't have baseline health data from the City Lake community. What we do have is what the lung function should be for different age groups. And by and large, they're significantly below where they should be.
Is this all people that were exposed to the ultra heavy particulate?
Yeah, these are folks that were living in City Lake. The average age of the study is in the 60s, so it was mostly older folks.
They were there the whole time.
And they were there. Some people did leave, but the people who left for an average of like 8 days. And this was a smoke exposure that went into like 53 days. So it was, an incredible smoke exposure, and it is quite extraordinary to see these effects. Now, these are his preliminary data that he's analyzed it, but it hasn't been published, hasn't gone through peer review, and I think he would say the study isn't complete yet because he wants to continue gathering data and really filling out the story. But he did go to City Lake to present this data to them first so that they would be the first to hear and not hear it through other sources that their lung function was still depressed a year out from the fires. Because typically we tell people you should bounce back, but that is not really based on this type of exposure. So it's
Because this is the worst particulate ever recorded, right?
Yeah, it's the worst like known longest duration of worst smoke exposure that we know now. And I'm certain there are other communities that have just not had a monitor.
Yeah.
Did younger people bounce back?
No. But I need to get his slides and.
What was the peak ppm, do you remember?
No, it was
off the
exceeded.
charts.
We
Oh, yeah, you see the.
Couldn't measure it.
Yeah, it was
Yeah.
measured. The highest 24-hour average we measured was over 600 for a 24-hour average, but there were several hours that were over 1,000 that we couldn't measure.
That's a lot of particulate.
It was just the mass particulate they were exposed to was really extraordinary. So anyway, it was a great talk, and I really appreciated having him come and share it with us. And I think that it's important to have these actual health studies where you're following individuals, because a lot of wildfire smoke research is by nature an epidemiological study, because you don't necessarily know specifically who was there for how long. And so this is kind of its own little category, and it's interesting and very depressing.
To anticipate a time when this would be not just in a journal article, but through a press release or something you guys would put out?
Well, I would want to wait until it's been published.
That's what I mean, right? When it's, after it's a journal article, or when, just to get it out to the greater world, rather than
I think its best application is improved fire management and firefighting capabilities is where it's probably best used.
Well, and one thing that I have going on right now is a push in the legislature for it's a bill that would lead to a study of indoor air filtration and our ability to create cleaner indoor air spaces in Montana, and put together best practices for the state, work with stakeholders, see how we can incentivize them to do better for their employees and their customers, and what we can do to move forward and prepare better for wildfire smoke, where when you tell people stay inside, that's actually going to be good advice.
Yeah.
So that's where I'm my focus is this idea that we need to be ready for wildfire smoke, because the smoke comes inside buildings. So you only have like 24 hours after a smoke event before the smoke starts coming inside. And depending on how leaky your house is, that's going to really vary. Like if you have a really leaky house, you're going to get like 20 exchange rates in an hour. You're going to get a lot of smoke coming in. So it's, I just really want to get that place where we prepare for wildfire smoke. And I think that is where the City Lake Health Study is something that might be an example of, we need to have cleaner air, because if you don't have cleaner air, you're just going to be sucking down the smoke, and it could be really harmful.
And the experience we had collectively of, first seeing the really alarm on your face the night when you came in and said, I just think we've got to I've never seen anything like this. We've got to do something in Saley Lake. And how, in the face of those flames and potential loss of home, how to talk about that risk in a way that could be actionable for people was just not satisfactory at all. Stuff like this might help, unfortunately.
Well, didn't they deploy like National Guard and stuff? So like responders got deployed.
Well, I think that when they did the official evacuation, they had to get a lot of people out there. Because of the amount of fires that we had in western Montana in 2017, I do believe the governor deployed the National Guard to fires to assist in areas that they were capable and trained to do.
I'm just thinking where you were putting first responders at risk and all that.
Oh, the fire camp, if you were out there and saw where the fire camp was located.
They were sleeping and there was smoke.
It was like an upside-down chimney just coming out over the top down the fire camp. And
So what would a study look like that would be testing indoor air quality with filtration?
Well, there's different ways you can go about it. You can have the really laboratory controlled study where you can control every single, air in and out and just have continuous monitors showing the effectiveness of that air cleaner removing particulates. What I want to do is challenge these consumer grade air cleaners with wildfire levels of smoke, because I know that they are challenged with that kind of a smoke exposure. We are actually in talks with EPA right now to do something like this. EPA came to me several months ago and said, hey Sarah, we want to do a wildfire smoke public health study with you guys. What are you interested in? And so right now they're really leaning toward, really seeing what good advice we can give people out of more advanced studies with air cleaners. They also, we want to do like field tests. We're doing a wildfire smoke season where it's under more realistic home exposures where you have people opening doors and coming in and out, and like what's the actual effectiveness in a real life situation. And then what I want to see happen that I don't know if we're going to get it to be a thing that occurs is I really want to get better information about larger spaces, like buildings like this that have an HVAC system. We recommend a MERV 13 filter, but we don't actually have a whole lot of data in a wildfire type situation with indoor and outdoor air quality monitoring to really give us anything other than we think it should work because it's the lowest filter that is rated to remove fine particulate. I want to have the actual numbers to back it up. We do know that if you don't have even a MERV 8, you basically have outside air inside. That's what we saw from some air quality monitoring that Clemson, Missoula had going on in 2017, where they had particulate monitors kind of throughout town and in places like the senior center and the Hellgate High School gym and the library. A lot of the times the air inside was equivalent to the air outside because there wasn't any filtration that even meets the current standards for new buildings to keep that particulate matter out. So that's where we're pushing for doing better, at least in Missoula. So all the new schools that are being constructed and remodeled, they have to come through this office, and Michael Dorshorst is amazing, and he has pushed them all to commit to putting MERV 13s into those schools because he's taken up my cause. But there is no statewide policy. There is no this is our state's best guidance. There's nothing like that. California just put MERV 13 requirements into their building codes for commercial and residential buildings. That went into effect this year. Or it goes into effect next. Anyway.
Was that because of their fires, or?
I don't know if it was in response to their fires or in response to their overall air pollution issues, because it started a year or two ago, the whole process of upgrading those filters. But that is now the requirement in California is a MERV 13. But the standard for building that everybody follows is set forth by ASHRAE, which is the Association of Heating and Cooling Professionals, and they only require a MERV 8 in commercial buildings and a MERV 6 in residential buildings. And so I don't think we can go like straight California.
kind of keeps the gravel out, right?
Yeah, but keep the castor out. And for most of the time, a MERV 8 will be great for most of the year. It's just that when you have a fine particulate concern, you do want to have a better filter.
What do we do if we have a similarly long and intense smoke event that's, say, in Missoula, as opposed to Sealy Lake, and we say, it's not safe to be here, and we can't say that it's actually safe to be indoors, where do?
Though the
what do
short
we-
answer, and there's a much longer answer, and even the longer answer is incomplete, but the short answer is we are working on as quick as possible deployment of the cash that we do have for schools of air filters. I don't know, why do I want to call it HEPA?
I guess I'm wondering, going beyond that, rather than
Yeah.
like, well, we'll just get air filters out, not that just, that is a great
Oh, no,
thing
no,
to do.
no, I mean that-
I didn't mean to minimize it, but if we get to a point where we realize.
Actually
indoor
move
air
people?
quality during this,
Yeah.
we gotta move people, and there are people who don't have the means to move.
Yeah.
What do we do with it?
I don't know, we've talked about that, and when we ran into that in Sealy Lake, and we did everything to help just the small population of people move, and even had shelters, or try to move at night, and in that scenario is the only experience we have. They were not gonna go for the most part, because they were gonna stay and watch their homes, and they were worried about the flames. Now, we saw some movement with schools being held for the opening days in another area. It's huge. I mean, to even move a small identified population is huge. Then you've got the issue, and I'm not saying it,
I
we
get
shouldn't,
that it's huge.
we shouldn't look at it, but then where do you move to?
Absolutely, and I don't have the answer.
And so,
I'm
you know,
just
you've
saying I
got your
see that
smoke
this can
coming, yeah,
happen.
you've just got this whole area. When you look at the satellite pictures that Sarah looks at every day, sometimes that whole northwest area's got plumes going all over the place, and then you move and they change.
It's just an open-ended question.
Yeah, but I think that's why, well, we realize what we've done so far is a little bit stopgap, that we have to do it in a more institutional way and do it with data and be more informed on how we do it, because I don't know, other than just moving a small group who has like the highest impact of that particular season, I don't know that you can do more than that.
Yeah, and there's, the struggle of, we have wildfire seasons that now last like weeks and even months at a
52
time.
days.
Yeah.
So it's a very hard ask to try to get anybody to go away anywhere for that long, and then where do you
Yeah.
go? So I'm really, really focused on sheltering in place and finding ways to help people shelter in place. The tricky thing with that is going to be the social equity and health equity aspect of it, because there are people who just cannot afford to help themselves, or they live in really leaky homes. And I do not have the answer to that, but I think that's something we're going to need to really struggle with as we continue to see these wildfire smoke episodes. But
It's like we need a sister city in Iowa.
Well, actually, Sarah and Amy are, I mean, Sarah and Amy, I'm not saying they're the only ones in the nation looking at it, but in terms of people looking at it on the ground and living through it and trying to find their way through and spread the word and learn, it's you. I mean, now we've got California not only looking at it, probably competing for funds.
There were much larger places than Sealy Lake evacuated last fall in California.
I just want to say that I really appreciated last summer before smoke season, you sent out some like, hey, everybody, if you don't have your filter clean,
Get it now.
Clean it. And if you don't have a filter, here are links.
And-
Because it was really easy for me to just be like, oh yeah, I do need a new filter for this level of my house. Click. And I know that not everybody can do that.
Right.
But those that can, to make it as easy
Yes.
as possible for them to be able to be thinking before there's a run on things, like I need to get myself in gear, I need to make sure my filters are checked, and like even doing that a few times leading up to the smoke season, I think those people that can help themselves, to make it as easy as that for them to do it.
And that is part of the plan that we discussed and you and Amy worked on.
That's great feedback, though.
Yeah.
And then I could forward it up to my mother-in-law and be like, here's some links, because she's like, I don't know, I'm like, here you go, here's some
Right.
links, and I can forward it to my neighbors, you know what I mean?
And then last year, we got, probably in the last 6 months before you were here, we got a report on the outreach to the daycares and the home daycares. And it's not a comprehensive approach yet, but it's, okay, what are the...
Because you guys have the portable air purifiers too, right?
Yeah, we have a cache of about 123 air
Right.
cleaners that we have, and then Climate Missoula has also been building their cache. Climate gives theirs away, which is nice, because it's like, it's gone, don't have to worry about it anymore, and I have to get mine back and clean them and stock them and track them. But we last year
We loan
We got them out, we contacted all of the licensed daycares and preschools in town and said, how many do you need? And got them all as many as they needed to
Mhm.
have clean space for their kids before wildfire season started. So that sort of thing is where we're trying to approach the social equity aspect of it and get the most vulnerable people protected, because some recent studies have come out that looked at wildfire smoke exposures, but the studies themselves just came out in the past year or so, showed that the kids ages 0 to 4 and especially 0 to 1 had like 100%, 200% increase of hospitalizations for asthma,
Mhm.
like a much higher like impact than what was seen in other age groups.
We would go to those meetings up in Sealy and try to talk to people about smoke, and you didn't get much conversation in the actual public meeting, where you get all sorts of conversation about where the flames are, where the camp is, what's going to happen, and I understand that. But after the meetings, then when people would come up to you, and they'd want a particle mask or a surgical mask or an N95, and they had heart disease, and you just kind of get that face-to-face sense of they don't even have basic information about what won't work that they're doing. They're taking actions that won't work, and some taking actions that are harmful. So there's like this moving forward, but kind of catching up with reality about the mask situation. We saw that in California. They all started wearing masks.
Yeah.
There's
It's not going to do it.
From what I've seen, I've been to some meetings, and the public health community seems just completely torn on the mask question, because some people, it probably will reduce their exposure, and some people, it's not gonna be all that helpful, or just gonna stress out their systems even more.
Yep.
And then people who think they want a mask, and they put it on, and realize, oh, this is terrible, so they just have it hanging around their neck.
Yeah, or they put it over their beard. That's my favorite one. It's like, that's
So
not working.
we aren't there yet. We're making a lot of progress, I think, with wildfire smoke. A lot of the attention that it's getting is really expanding throughout the public health and emergency
Mhm.
response communities. There's been a lot of meetings happening. I've been to a lot of those meetings. I'm going to a lot of those meetings when we're talking about how to communicate the best, what messages should we be giving out. The mask thing comes up over and over and over again, and no one has the right answer, because both arguments are correct.
And there's not data that'll pull it either way.
Yeah.
We researched it heavily in 2017, and Shannon and Sarah and I, and looked everywhere, and Shannon finally got her hands on something out of California that was adopted, and it's stuff that we wrote in 2000. It was the same thing.
There's some types of masks that were definitively successful, and
The ones that you
There's
need
argument.
truly to protect against something that small is called an N95. It's really a respirator. And there's just so many things that you have to know on an individual level, whether you can wear it, if you're wearing it correctly. And if you've got health risks, you might think, well, I'm exactly the person who needs it. No, because you can't move enough air through it.
And if you
So-
work and wear one, you have to go get certified by a health
Yeah.
professional and actually get
It's- yeah,
respiration
so-
tests and all sorts of stuff to even wear in the work
And
environment.
they
so
don't
you
make
can't,
them
and
for
you
children.
can't just go buy one.
Oh, yeah,
Oh, you can
go to
buy
Home
it.
Depot and buy one.
You can buy it and wear it, and you might
You can
feel
also make
better,
your
and you
heart
might feel
disease
worse.
Because you're not pulling it in a box.
If
Or
it fits you,
cause
if it fits you
pulmonary
correctly and you have a health condition, you're not getting enough air. Like a pregnant woman who's working as a nurse that needs an N95 for a whole shift cannot wear an N95. She has to wear a different device that actually brings enough air to her.
Forced air system.
And if you are wearing it, it has to fit.
Why a nurse? Why did you?
I'm just saying that's where we
Upright
get,
and moving around.
that's where we get some of our evidence from and some of our guidance from, our healthcare providers, because an N95 is also useful for organisms, not just for, and so you look at that and you go, some people shouldn't be wearing this. But these are the kinds of, we could sit down and have a whole discussion to what we've tried to do to date, and then some of these ideas about how to go forward. I think we could have a special session just to do that.
Yeah, maybe ahead of fire season.
Yeah, because, we went through it and worked through it, and so we have a lot, but it doesn't answer your questions in a really systematic or guidance-type way.
The same way what you did with the air filters was helpful,
Yeah.
and the
Right.
same type of information around masks
Right.
would be helpful to many, many people.
Yeah, except with the air filters, we actually have some data.
And like the tips, like, sleeping in clean air and
Yeah.
all that was so useful to
Mhm.
me to learn those tips and then to remember them for last year. We didn't have
Mhm.
much smoke, but I just think like accessible, easily understandable
Yep.
lay people tips and links
Yeah.
is the best way to get as many people on
And
track.
infographic is
Really?
what most people seem to
Mhm.
pay attention to.
And it really helped me to understand, like, I might as well be outside without an air filter. You know, once I really put that together, my kids might as well be sleeping outside
Yep.
in this
Yeah.
without air filters in their rooms. That is what
That
really
is the
got
shift,
me on
isn't it?
board.
You know, we actually experienced that shift here because for how many years during winter, we'd say, it's bad, keep the kids in for recess. Well,
It's the same.
it was the same.
Yeah, and that's gonna depend on your HVAC system and.
It depends
if you're
on-
opening windows or not, and.
If you're doing jumping jacks or reading.
Has a lot of, there's a lot of stuff into it, but it's
Yeah.
very easy for your outdoor air to really quickly influence your indoor
Yeah.
air if you're not taking
Yeah.
active precautions.
So we should sit down with you, Josh, and anyone else, and
I'd
talk
love
more
to.
about what we did and how we tried to capture it and how we're trying to move forward, and it's, yeah.
So we need to be mindful of time. You had
Okay.
a third?
Yeah, I had one other, and it was actually Amy from Climate Smart Missoula came and just kind of gave us an update on a lot of the awesome things that she's been doing because, oh my goodness, she is a busy
Yeah.
woman. They do a lot of great stuff, and so we breezed past the wildfire smoke stuff because I presented on that to the advisory council enough that they
Yeah.
know what we've done together with that, but she presented a lot of other really neat things that Climate Smart has been doing in the community to just really help us all out and make forward momentum happen with responding to climate change and preparing for the changing environment. So it was great. It was a good meeting.
Good. Awesome.
Thanks.
Next up is TPCC, which didn't happen. It was
Yeah.
canceled. So we can just skip that. The next meeting is scheduled for April 16th. So public comments for items not on the agenda. Jan, you have something?
Sorry for your long wait.
That's all right.
That was a long
I know, when we have the time, we get so engaged,
Well, you've had a really interesting meeting.
It has been.
A wide range of subjects, so I didn't mind being here. Good to see you here, Josh. My name is Jan Hoang, and my husband Harold and I have made 5 trips to Helena to talk to committees, mainly on legislative issues related to climate change, trying to restrict coal emissions, and those things which affect all of us. So we were there this Tuesday, and we sat in on the Energy and Telecommunications Committee, who were going to discuss a new Senate Bill 331 that was written to replace Senate Bill 278. And the main reason we had gone there is because Senate Bill 331 is really going to increase the rates that Northwestern Energy customers pay. And Harold and I have both been emergency medical technicians in a rural area, and the majority of the people that we transported were not the sexy calls. They were elderly people who needed our help. And going into their homes, we saw that they are living simply. And some of them had their thermostats set at 55 or 60 in order to keep their heating bills down. So we look at Senate Bill 331 as a bill that is not good for the public, not good for our health, and needs to be stopped. Northwestern's Energy 2019 energy procurement plan is going to be coming up soon. It's the comment period right now, and that comment period ends on May 3rd, which is a really awful overlap if you're involved in legislative things.
Is that with the PSC or is that the legislature?
No, I'm going to get to that. I'm headed there. Okay.
Did you say Senate Bill 331?
Senate Bill 331.
Thank you.
Right. And I have 2 articles I want to pass out to you. The first one is a letter written by Travis Kavula, and he was chair of the Public Service Commission for 3 years and has been on it for a long, long time. He's a Republican, but so currently is every other person on the Public Service Commission. And Travis Kavula is a really intelligent person, and he is writing against Senate Bill 331, and his explanation of why is very powerful. The other bill that I passed out is Leah, what is her last name, Larson, and she writes for the Montana Free Press, right. And she's a very good reporter, and she wrote on the session that I'm going to talk to you about just briefly, and then I need to let you go because you've put in a long day. And she has one more article that describes what happened when we were there on Tuesday, which was pretty interesting. So Senate Bill 331 was brought forward by Senator Tom Richmond of Billings, and he had brought forward the Senate Bill 278 that received such a hue and cry that he was happy to remove it and replace it with this one, which he thought had more side rails to control its effects, but in effect it did not. So let me just tell you what SB 331 does. It removes the risks from shareholders and owners of Northwestern Energy and transfers those risks to the ratepayers, and those are financial risks. The Public Service Commission, which many of you know about, was set up in 1913 when legislators realized that the people in this part of the state, as far out as Great Falls and beyond, were going to have a monopoly utility. And so the Public Service Commission was created to have somebody who would balance the needs for financial gain by the utility with the needs for the ratepayers to have reasonable rates, as reasonable as they could be made. This bill is opposed by the Public Service Commission's staff, those who have been there for years and years. You know, your staff people know so much, and you rely on them for information. The same is true of the Public Service Commission. However, 3 of the 5 members of the Public Service Commission have come out in favor of this bill. One of them didn't vote on it, and the other one, Commissioner Koopman, came out very strongly against it. And you will be reading some of his words in what I gave to you. So please read those articles. They'll fill in the 1,000. There are so many weeds on this bill, so I'm keeping what I'm saying as simple as I can. One of the big things that happened when we were there, and in a way not a lot to do with that bill, and in another way it does. The bill's sponsor, Senator Richmond, in response to questions from Sue Malik, who is our senator and a very gutsy lady. She has, I'll get back to what she did there, but I just have to say, we've seen her in other settings where she was the only person who stood up and spoke out in favor of doing things toward controlling emissions. And you know, she's in a setting that is many times hostile to what she has to say. Anyway, she asked questions to Senator Richmond about why they wanted to take control out of the hands of the Public Service Commission in terms of looking for fair rates and balancing all of that. Senate Bill 331 removes the Public Service Commission from that process. There will be no oversight by the Public Service Commission on Northwestern Energy's rates as they relate to the ownership, maintenance, demobilization, and cleanup of Coal Strip Unit 4. And right now the DEQ estimates those clean up just of the ash ponds at coming in somewhere between $400 and $700 million. So, and also, this bill gives Northwestern Energy a 30-year period in which they can collect the money to cover these expenses. So they may be collecting money when they're no longer providing energy. This is why there are people who have looked at that bill and say, this is a badly written bill and it's a really poor idea. Anyway, what Senator Richmond said is that one reason for taking the Public Service Commission out of this process is so that they wouldn't be influenced by people like those coming from MEIC and those who might not hold, well, he specifically mentioned MEIC and their ilk. And Sue tried to pin him down, and he just said basically the same thing several times. Finally, so that was really disturbing, because democracy involves public participation, and that was a limitation. Finally, a few words about the League of Cities and Towns, of which Missoula is a member. The League voted on a resolution in September, not this bill, to support the community of Colstrip, you know, the re-education and whatever they could do. So Kim Burton, who is the executive director of the League of Cities and Towns, spoke to this group in favor of SB 331. But before he left the room, he was overheard to say, "Whoa, I think I'm on the wrong side of this." Kim Burton is now getting calls from eastern Montana cities who may not even be Northwestern Energy's customers, telling him to support the bill. But we, Northwestern Energy's customers, are the ones who are at risk. And I believe Kim Burton needs to hear from cities like Missoula who are implied to favor SB 331. You can see how that happened. We agreed to support Colstrip in September. This bill didn't appear until a week ago. And here we appear to be supporting it because we're on the League of Cities and Towns roll. So I'm hoping something can be done about that. And that's all I have to say. Thank you for your time.
Thank you.
Any questions?
I'm just assuming you've been to City Hall as well?
I made a phone call to Mayor England's office and spoke with his legislative liaison person.
Yeah, Jessica.
And she helped me understand how it was
How they work.
that we're on this.
Yeah.
It doesn't mean we really support it. We supported what they discussed in September.
Thanks.
Thank you, Jen.
Thank you.
Any other board or staff comments on items on the next agenda? Hearing none, we're adjourned.
Thank you very much.
Nick or Tony?